Good morning. Respected distinguished guests, esteemed faculty members, dear colleagues, residents, and participants. It is a great honor and privilege.
Specialty Surgical Institute, Guwahati, Managing Director of Swagat Hospitals, Dean at the Swagat Academy of Medical Sciences, and previously he was Professor of Surgery at the renowned Medical Hospital. He's been President of the IAGES, and he's contributed significantly, I think, to all branches in surgery, especially to minimal invasive surgery. And he's a recipient of the B.C. Roy National Award, the Lifetime Achievement Award of IAGS, and it will be an honor and privilege listening to him to deliver the Professor S.C. Mishra oration. For the youngsters, Professor Mishra was a visionary surgeon. He was the head of surgery at KGMC, and he started his career as a professor of surgery, has established the experimental surgery unit in the Department of Surgery, and a lot of other innovative things, and a person who would really think, a thinking surgeon. And the new surgical block was something which was built during his time. With this, I request Professor Subhash Khanna, sir, to deliver the oration.
Thank you very much. Thank you. Thank you, Chairpersons. Thank you, Professor Mishra, for that kind introduction. Respected Professor Avidav, Professor Mishra, Professor Sablok, all the faculty, students, delegates, ladies and gentlemen. I bring greetings from the Northeast, from the state of Assam, and my talk is based around that only. My address today would be, which doesn't belong to any geography. It belongs to vision. What you visualize, you can achieve that. You can create your own future. I come from a place of the world which was never in the map of surgical world in India and in the globe. Guwahati was not known 40 years back when or 45 years back. Technology has begun to shrink geography and surgery doesn't know any boundaries. Things have changed in the last 3 decades. Laparoscopic has taught us how to do surgery differently. Robotics have taught us how to think differently. Telerobotic has taught us geography, distances can be minimized. I'm not talking much about technology. I'll be speaking in 3 parts. It's 10, 15. Part 1 would be a little bit about my journey. Those who have heard in the past may kindly bear with me. A little bit about the technological revolution going on today, and maybe ending with a little bit of what is future going to come. I'm greatly honored to be presenting this oration in the name of a visionary teacher, professor, examiner, thinker, Professor S.C. Mishra. And I fully understand, I fully know that every advancement in surgery is led by people like Professor Mishra, who had visualized something which is happening today, much ahead of time. He was one such person who could visualize that tomorrow composite departments will come, people will be, same department will be having research wing, education, teaching, training, and theaters, labs, everyone will be connected to each other, and there'll be a composite department, which is happening today, but he saw it 40 years back. He was the one who could visualize a formal teaching, training, curriculum which is happening today. He was much ahead of time. I'm privileged to be delivering this oration after his name. It's always remain a great honor for me to be invited here, and thank you very much once again for that. He was a teacher to the nation. He was an examiner, I'm told, though I have not met him personally, because when we passed, I think I did my MBBS in 78, 79, so he was much before us. But then he was a teacher of the nation, teacher of all the teachers, and most of the teachers here also. His legacy lives on. If modern surgery represents progress, then pioneers like Professor Mishra remind us of something deeper, that progress is not inherited. It is built. He built it. He built it with his own hand, with his own vision, and passed forwards to all of us, to all of you. Ladies and gentlemen, my journey is from a very modest surroundings. We are displaced people, like most of the Malhotras, Mehras, in movies you see many Khannas and Punjabis are there. We are all displaced from West Punjab, now Pakistan, and my parents were born in a small village in Lailpur and near in Lahore. My father had never seen a college, and my mother has never gone to the school. But they always kept telling me, they always knew what is the role of education in our life. They also had unlimited aspirations from all the children they have. I've never gone to any convent school, and what I learned was, you can see rupees 4 and 12 annas, AS is annas, getting small books, imbibing all the stories in me, in us, and that's how we grew. We used to buy books in 2 rupees, 4 rupees, second-hand books, and some annas, and we learned all those, and we picked up, even English I had to pick up because I'm from a Hindi medium school. There are so many of these which we had to study to struggle with the West. Now, yes, we gave the same education. You may be a great teacher, great surgeon, but you will not educate your children. How will you educate the other students? My elder son, Anshuman, orthopedic surgeon, Ayushman, intensivist. I have 2 sons, 2 daughter-in-laws, colorectal surgeon, Chaitra, and Rupalim is an ENT surgeon, and I have 2 grandchildren also. Maybe you can think that they're also going to be future surgeons or doctors. Of course, one wife, Professor Swagata, she was heading the ENT department a couple of years back. I always believed in one idea, which I would like to imbibe to all the students here, if you are, or even the young faculty, an idea which should be there in your blood, in your cell, in your body, in every molecule of your body, in every DNA and RNA, an idea. For me, that idea was surgery. For you, you may have a different idea. It may not necessarily have an idea for surgery, but an idea should be there, or a vision should be there. And I think that was a vision of Professor S.C. Mishra, about whom we are remembering him today. And definitely, I was inspired by that. And that inspiration led me to take up many things very early. Surgery and telerobotic surgery. And telerobotic surgery. So there are 4 people as per the Rogers curve. Innovators, you may not be always, you need a lot of labs for. Innovators, you may not be always, you need a lot of labs for that. Early adopters, you can always be. This 11 or 12% of the people who are early adopters always think differently, they take the risk, and also they suffer sometimes with a lot of financial loss. We put money in many projects which are yet to come. ESWL came for gallstone, disappeared. It became a failure. You put money and your money is wasted. But then this official document, a permission for lab training, think of this when I took its permission on 10th of September 1992, when we had heard Professor Udwadia speak, showing his first video in 1991, November, December, when I was attending a meeting in Goa, an International College of Surgeons meeting. I was standing on the back end, and we came back and just took a permission from the government. There was no laparoscopy department existed, but I thought we must have a certificate proper. We must have a government certificate. Getting training in laparoscopy in an institute where even today, about 4 years back, laparoscopy started in Medical College. I was trained in that hospital because I have a government certificate, and took out all the instruments from the store, which gynae used to do tubal ligation. I started doing adhesiolysis and appendix in the gynae department. And assistant professor of surgery in 1992, attached to gynae. People did not know, they might, even you, when if you want to do something different, people think that you are gone. Okay, so this was the beginning of innovation, and this probably was the beginning of this small approval, administrative approval by the government and by the principal of, was the first step to a journey that eventually led me from open to laparoscopy to therapeutic endoscopy to many more things, and finally to robotics, and now to telerobotic surgery. So journey doesn't start with robots or with technology. It starts with small thinking, small thoughts. Small single chip cameras, small monitors. We started doing very simple instrument, a small 150 watt halogen light source. Those of my age will know how we start from halogen to metal halides to xenon to LEDs, how we have transformed ourselves over the years. Yes, there was a remote support and influence by Professor Kusheri, with whom I was trained in Scotland, in Dundee in Scotland in 1996. And of course, Mrs. Sybil Storch was there to provide me a complete set free of cost from Karl Storch, Stuttgart, Germany. She just left last month. She's no more. And Professor Philip Murray, whom I used to talk frequently, the man who did first lab cholecystectomy. And these were people who taught us that learning, progress belongs to people who are ready to learn even before something is established. I went on to do single hole surgeries. I cannot share with you how did we do that. And I used to use the endoscopic basket and hooks and put it in the sheath of the laparoscopic instrument and try to do a single hole surgery. And later on, I developed my own technique. I think people might be doing this way now, of rather than using a very expensive the single incision ports, Sills ports. I went on to do single incision laparoscopic surgeries. And we perfected this art, me and my whole team members. They can do Sills cholecystectomy in about 15-20 minutes, not a problem at all. We perfected many more things, starting from this, ERCP, spyglass cholangioscopy, which became routine. In all were the things which we gave from our state to the Northeast to the rest of the country. I went to Italy and worked for a few days with Piercarlo Monro. You will see who was the person who produced instrument, WAF instrument, and thereafter more than 1,500 to 2,000 fistula, starting from fistula occurring in the back to the buttocks and to the pediatric age group. So there was no looking back. Yes, sometimes the thought may not work. I came up with a book, Recent Advances in Minimal Access Surgery, because Roshan Lal Gupta used to write Recent Advances in Surgery, and after him, I tried to take up that book. I could not. And first 5 editions, not sold. 200 books I bought with my money and distributed among all the medical colleges, all the HODs, whomever I knew. And suddenly, my 4th edition, 8,000 copies were sold because some pharma company took it and gave it to all the surgeons across the country. Things may change overnight. Perseverance and accidental encounters do happen, which you never know. But if you don't try, it will never happen. Coming back to the second part of my talk, robotic surgery was there it's not a sudden revolution. Even in 322 BC, people used to imagine a self-acting tools. If I could have some tools which can work on my own, on my instruction, I don't need any apprentices, I don't need any slaves. So this was what philosopher Aristotle thought those days. And later on, we all know about Leonardo da Vinci, and I have named my second son Leon after Leonardo. Okay, so he was the first, he was a polymath, he knew many subjects. He was the first who gave us the idea of robots, and long before the computers, electricity, and all these things had come, he could imagine that a machine should come, will be there, and he developed this knight which could wave, and we could bow down to your commands. But the actual name for the robot comes from a Czech term, robota, means slave. This was a playwright, Karel Capek, who gave this term robot, and this is what, from that day, we started this term knowing robot. But it was not very popular till this movie, Metropolis, came in 1937, when robot Maria was shown as a humanoid structure which could convert into a normal human being and convert into robot at the instruction of the producer, director, or inventor of the robot. This was the most popular, influential German science fiction film presented where there was a futuristic city shown. The term was made more popular by Isaac Asimov, who was a Boston science fiction writer. He wrote several books, and almost all the books were around robots only. But then the father of robotics is Joseph, is it working? Engelberger, who produced a machine called Unimation, and this machine, for the first time, this was Unimation Puma 001, and this could do a repetitive movement in factories, in General Motors, and from there the idea came, and in Long Beach, in the Memorial Medical Center, the first stereotactic brain biopsy with a precision of 0.5 millimeter was done with the same machine was used, which were produced by Joseph Engelberger. So same machine with a precisely you could take a brain biopsy. That was in 1985. We had to wait for another 6 years before the urologist gave us the robot for a prosthetic surgery in 1991 and 1992 later on by the orthopedic surgery. But the next revolution was telerobotic, when this man, Professor Marasco in IRCAD, Strasbourg, sitting in New York, he did a surgery in IRCAD, Strasbourg, and this is the world famous operation known as Operation Lindbergh. Da Vinci got an approval in 2000, and thereafter they developed various types of robot, and today they have a version 5 going. I think we are having one of these in KGMC, and they have many features which other machine may not have. The main features that they have is a iris technology, which creates 3D model from diagnosis. So you have a CT scan, you don't have to look at the CT, you can create the image and have it on the screen alongside your, while we are doing a surgery. They have a Firefly technology, you can see the ICG images on the screen, which we today, if I have to do a CBD, I have to again go back to, from my system, I have to go back to laparoscopic vision again and have a look at the CBD, and so it becomes very difficult for us to do. They also have advanced energy, dual consoles, and choice of staplers. But in 2019, things started changing because most of the patents of Intuitive started expiring, and there will be many robotic platforms came. So from 80, in 2022, we started the Robotic Society. There were only 80 to 88 systems in the country here. And suddenly it shot up, and today we have 476, almost nearly 470. This is a figure last week I collected from all the robotic companies of the country, with Intuitive having 250, SSI Mantra having 150 in the only 3.5 years, and Versius about 60. The graphs changed because the general surgeon started taking the robotic surgery in a big way, general surgeon. So they were here till 2016-18, and suddenly it shot up and robot went to the smaller towns. Today, we have 6 robots in the country at present. Apart from Da Vinci, we have SSI Mantra, Hughes installation, CMR, Versius, Medtronic, Hujaras, very little impact in the society. Mijo is going to create waves, and then the Medbot Tumai is one of the biggest country having many robots. So SSI Mantra tried to democratize the innovation. This is an indigenous platform, cost barriers started reducing with the SSI Mantra came into being, and they have about 140. In fact, yesterday, they completed 150 telesurgeries or remote surgeries. So this is it. These are all open platforms now, most of them, except 1 or 2. And then came the Versius. The first was the Versius after the Da Vinci to India, and I'm a user of both Versius and the SSI Mantra. So these are all based on open platform. You don't have to put your head in the system. Marilyn Mizo has sold about 10 in 9 months. It's good. It's a replica of Da Vinci. But as is Medbot. Medbot has robots for all the functions, starting from robotic hair transplant, where you can pick up the follicles with precision, to the ortho robots, to vascular robots, to the laparoscopic, multi-port, and single-port robots. The Edge Robotics is knocking at the door. By the end of this month, they will be here. So altogether, not 92, about 112 countries in the world are trying to be robo. The main purpose is to make surgery comfortable and receivable, affordable for each human being or each remotest person in the remotest part of the world and the country. The main work is being going on is about the level of autonomy, how much autonomy we can give to the robot. Whether the robot will do everything full autonomy or maybe part of the autonomy. So today we are at this level, probably LOA 1 and LOA 2, where the robot is being controlled and some amount of autonomous movement autonomy is allowed to the robot. We had been trying to have a robot since last 2010, and we saw all the certificates given nothing against any company, but when you go and read the certificate, it's either about introduction to the OCS or it is about the console surgeon. You are not a surgeon. A person who sells Mercedes cannot give you license to drive Mercedes. License is by someone else. Please remember that. So we saw all that this doesn't give you safety because half of my family is also in law, and it was so difficult. If you want to get trained by Da Vinci, you had to pay amount of 5.5 lakh, and that's for a 2 days training. So I thought, why not we change, and rather than to curse the darkness, why not do something else? And this was the reason we started a systemic training and introduction of the systems to computers from university course, with everything being under software based with different modules. And this is what we affiliated with the Sri Ramachandra Institute of Higher Education and Research, and the course is endorsed by them. Not only that, we also affiliated ourselves with the Royal College of Surgeons, Edinburgh, and the course is endorsed by them. That's why we get overseas delegates also. This was our first batch of delegates who did fellowship, and now this was a collaboration with the Rowan Parks. The president now, the next president is Claire, who is coming to Guwahati to give certificates herself. Urology from Onco or from Gynae, whatever being done. I think urology was most of the work was being done in urology, and we started doing general, GI, particularly pediatric. I have seen many of the work being done from pediatric department here also, because like getting some videos in competition also. and then thoracic, cardiac, vascular, and head and neck surgery. In hepatobiliary surgery, I won't name all the procedures which we are doing because I think I have about 18 minutes more. So the difficult cholecystectomy started becoming very easy with angulated instrument, precision, and comfort of the surgeon with lot of ergonomic benefits. The surgeries which were looking difficult, like gangrenous cholecystectomies, started becoming easier, although it looked difficult in the beginning, but then they started looking easier. So was post-cholecystectomy cases where we could do easily, and also a CLD, particularly child B, where we do not want to detect the liver at all. So all these cases which looked difficult, supposed to be difficult cholecystectomy, were difficult, of course, with robotic also, because the basic principles are same, but they started becoming much easier for us. The hernias, probably last 112 hernias, I have done almost all of them robotically. The moment we started increasing the number of cases, the cost started coming down. And basic difference was ease of dissection, dexterity, 7 degrees of freedom of movement, and ease of suturing. The bilateral groin hernia, which used to take a lot of time, 2 incision in open surgery, a lot of dissection in laparoscopic surgery, became much easier, and we could do a proper dissection with 3 or 4 centimeter of margins around the hernial opening. We went on doing a true general surgery with robot. We went on doing a simpler procedures like torsion to mental mass. Let's see what happens, how comfortable you are. And you can see these become very easy. But anyway, this is easy laparoscopically. This was a learning phase. If you don't do some of the basic work, how will you do advanced work? We went on to do gynae in Assam, in our state. Even gynae are done by many surgeons. And this is the rule, I think, in our country, in many of the people in remote places also do a lot of emergency gynae work we have to do. So, and we could do much more precise. A young girl of 18, if you want to do a dominant cyst, if you want to save the ovary, you have to be very, very precise. And these are all my surgeries only. So things started expanding, horizons started expanding. I was not doing much of upper GI advanced work like achalasia, the fundoplication. I used to find it very difficult, and it became very easy. Consecutively, I have done 64 robotic fundoplications without any laparoscopic case, and I will not do laparoscopic case. If you promise yourself, keep your promise, and then you see the people will start asking for that. So all these surgeries, which were supposed to be much difficult, started becoming easier because of the ease of access. I think I will go to the urology work. Professor Baba, forgive me of that. So we started doing this work also. And of course, as a general surgeon, for the last 40 years, I've been doing some of the work. So undescended testes, where we need to lengthen the testicular vessels, lengthen the walls. It became so easy doing this work. And I'm not talking about advanced work, which also started becoming easy. These are one of the basic things. You can see nicely how the walls can be lengthened. And here you can see, now you can pick up and see what the convolutions are there. You just have to straighten it and dissect it properly, and then you'll be able to take it down. The twisted ovarian cyst, the next came. What next? What next? Can I give this facility to my people sitting remotely? And we talked to the SSI that in the Eastern India we want to do for the first time, and we did 2 telerobotic surgery at a distance of 1950 kilometers with me sitting at a surgeon console in Gurgaon, and my team, I could speak to my team, I could see that. So this was done on the 9th of September 2025, the first 2 cases we did telerobotic. We followed all the guidelines. Please don't start thinking about it. The consent for surgeon, remote surgeon, consent for the local surgeon who is there, introduction of the local surgeon with the patient, everything was done, and a proper tripartite, 3-party consent was taken, and that was the completion of this. I can see tomorrow one procedure may be done by 3 surgeons. Suppose I'm doing a robotic surgery where I'm trying to do a nephrectomy where the kidneys attached to the liver and biliary tract. Professor Pravinder may ask me to do the bile part duct sitting in Guwahati. He can do remotely from Lucknow the nephrectomy for me. So this is going to come. This is not future. One patient will be operated by 3 surgeons if they has the 3 pathologies at the same time. Or same person would be operating on 3 patients, 3 centers across the country sitting in his center. This is going to happen not 10 years, in next 1 year. So what is next? Next we are trying to have single port system. Da Vinci has this system which is still a bit crude. I have had hands on this where you can make a 2.5 centimeter incision, put the port and all the instruments inside both, and you can maneuver all the instruments from sitting on your surgeon console. But then it's very easy. I tried my hands on Strui, and this is another single port platform coming from China. This will change the way we practice surgery. If you're doing a myeloplasty, you just have to make an incision, and put a single port and go to the instrument. That's like the ureter. And it's fun doing this. You can control the speed. It is so nicely it can be done. So this looks very bulky, but the opening is only 2.5 centimeters. Single hole, you carry whatever. This is what we want to do in endoscopy. I have tried where I have basket, I have balloons. How many hands I need, how many assistants. If I have this, if I have control of all the instrument in my other console, I should be able to do this. Hopefully they will be in Guwahati bringing the instrument. There is no problem in China bringing the system to India. And this is slightly superior to or equal to SEP platform of Da Vinci. The next is miniature robots. And we have been bringing big machines to our operation theater. Can we make it smaller, miniaturized, and adapt to all the Asian, Indian operation theater, which may be less than 300 square feet size. So while the current systems are all large, the future is to miniature robots or the robots which will be made on more on this which will be able to do transfer robotic surgery. So we are trying to make it smaller, portable, affordable, and accessible to all. They got appeared in 2024 the virtual integral robot, which weighs only about 8.5 pounds, and you can carry it, and that's why it is being thought that this will be taken to the space, and from a person sitting in the earth can control the console there. So this is the Mira robo, also called miniature incision robo, and the tip instruments they're not multiple instruments. The tips are very small. I think let me show you the tip. So these are the movements where you have a telescope. This has an FDA approval now, and you can see it can be taken to a gel port. I just want to show you the tip of the instrument. These are the tip of the instrument. So whole instrument which you are changing today need not be changed. Only a tip instrument will change. The semi-flexible robots have come. These are all rigid. The semi-flexible are one which you can do a trans-oral surgery, take it inside, flex it, take it inside. Once you are in position, you can just tighten it and make it rigid. So this also has got an FDA approval. And I think if the video, you can just see the robotics. I have about 5 minutes. I'll try to finish by that. So you can see this is semi-flexible. Now you can take the instrument. You can do posterior pharyngeal wall, larynx, vocal cords, anything. The EndoQuest robotics are again a flexible robotic system, mainly being used for transanal surgery, where you can take, you can excise and repair something like a transanal minimal access surgery. If this video runs, I can just show you how this is the concept, and this, I'm not sure whether it has an FDA approval, but it is very easy because I do TAMI surgery. It's very easy doing transanal surgeries. The Hinatori robot is not known in the world, but is only from Japan. They say that we have more than 7 degrees of freedom of movement. I think hysterectomy, all the gynecologists here agree that the hysterectomy started with transvaginal only, and we are going back to those where robot, and this is already in market. I think it may not have come to India. Merrill has one today. They have imported, and with this you can just go to the posterior fornix and go and do a retroflexor instrument. And this is a real video, and not mine, of course. And you can do the bronchial robots are there. The suction devices are coming, by which there was a problem when I'm doing a surgery. I don't have a robotic suction. I don't have a place to put a gauze piece inside. We used to use an extra port, which I use routinely. So now robotic suction devices come, robotic staplers have come. Robotic endoscopics is knocking at the door, where the surgeon would be sitting on the console there and manipulating his endoscope in the body, whether the assistant would take the scope and put it in position, and after all the manipulations would be done by the surgeon sitting on the console. One of the recent things which I saw, I think this must be known to all the plastic surgeons and vascular surgeons here, is Simony robot, which is a vascular robot, a tiny one by which you can do a suturing of the smaller blood vessels to the tune of, you can get a 20 times magnification, 0.025 millimeter suturing also can be done. So this is our surface robotics which are coming for amputation, or if there's an accidental amputation, very beautiful revascularization and nerve repair can be done. So this is the concept which I had hands on, and it is lovely. But the tip cannot be seen. I had to put a magnifying glass to look at the tip of the instrument. It's so tiny. Here it may be shown enlarged. So this is one trans-prostate biopsy along with an ultrasound in the anal canal is happening every day. Mako has come with a orthopedic robot. Can I have some water? Some water, please. Endovascular robots. The Corindus system is a robotic platform. Thank you. It's designed for coronary angioplasty, peripheral vascular intervention, neurovascular procedures. You need precision. Your cardiologist may puncture the pericardium, may cause a pericardial effusion. They puncture the heart also many a times. So you need precision. Thank you. So we need vascular robots, and this is what we have now today. Hair restoration, I think many of us need. This is for Professor Sonam. Automated robots have come where you should be able to do suturing uniformly. If my hand movements are faster or slower, same anastomosis, if I try to do same anastomosis twice, every time it will be different because my hand is trained, but I may not get the same movement every time. So we need some automation where every movement can be done uniformly every time. Some of the companies have come with miniature robots, and this is one example of miniature robot. India, AMS is marketing a robot where you don't need big machines, just a handheld robot by which you can do some of this movement. You may not get the ergonomic comfort, but you'll be able to suture it properly. Not classical robot, they try to call it a robot. These are all motorized laparoscopic instruments which are called. So future belongs to miniature intraperitoneal robots which can go into the cavity, you can restructure it inside. It will do the job. So right now, robot is doing everything from outside. Next is miniature robots which will act as instrument inside the human body. You will program it, you will control from outside. Okay. New ideas will come. Robotic capsule endoscopy will be there. I think I have crossed the time. It's exactly 40 minutes. And I will finish with two small statements. Telepresence and miniaturization is going to be a routine thing in the past. Remote surgery already 200 surgery done in India, so there's no looking back. By the time people are done, the future of surgery will not be defined by machines and build, what we build, but it will be defined by who will get this, who will be able to remove the distances, between and regions, distance between the care and the patient. If machine is there in one part of the world, if the patient doesn't get, it's of no use to humanity. Ladies and gentlemen, thank you very much. Once again, thank you, KGMC, for this persons.
Coming all the way to Guwahati, the famous
Dr. Bharat Durve sir. And next, I would like to call Dr. R.B. Singh sir. Sir is a general surgeon with special interest in advanced laparoscopic surgeries and advanced hernia repairs. Sir, kindly raise the dais. Next, I would like to call Dr. K.K. Singh sir. Sir is a professor in General Surgery Department at King George's Medical University, Lucknow, and he is known for his expertise in laparoscopic and minimal invasive surgeries. So kindly preside over the session, please.
Good morning, one and all. It's a proud privilege to be here, and I'm always happy to be back in this magnificent auditorium. In 2016, I remember they called me for a guest lecture when I did my first cardiac transplant in Bangalore in 2015. And believe me, what a proud moment this is to hear my father's late Professor P.C. Dubey's oration. A legend in himself, a man of many achievements, a humble human being who actually worked with his full heart and soul. So let us now call on Dr. Sonam Dukpa, the GDMO Thimphu, and the first pioneer surgeon from Bhutan. And I'm sure there are a lot of issues which we'll see in his talk, which says the unplanned destination and his journey of fulfillment. Dr. Sonam, the dais is yours.
Good morning to you all. I bring greetings from Bhutan, honorable chairpersons, ladies and gentlemen. It gives me a great honor to be here in this beautiful city of Lucknow and the very famous and quite an old university in the world is King George Medical University. I am very grateful and honored. In fact, I must thank the organizing committee, particularly Professor Sonkar, Abhinav Sonkar, for inviting me to this very auspicious occasion to give an oration to the pioneer Professor P.C. Dubey. And I'm so glad to see that his son, as a cardiothoracic surgeon, already doing so much of heart transplant, and also some of the daughter and someone is there, I believe. So it's a great privilege to get this opportunity to talk, give an oration, and it also inspires me that we worked in this university for 32 years, and I'm happy that I worked in my country from being a surgeon for almost 40 years. So that is really inspiring to me, and I would always expect the torch to go on and surgical development continue. Well, after listening to such an innovative talk, oration from Dr. Khanna, I can't imagine how far the development is taking place, innovation is taking place. Like in my time when I started laparoscopy, I was so happy. Now I can do something much better and easier. Now after seeing his miniature, innovative laparoscopes and capsules, I can't imagine how long it will go on. I'm sure one of the days later on where I may not be there, but this young surgeon sitting here may innovate further to make it more easier than what it is today. That is the development in surgical field, and development has to go on. Well, let me well, this is oh, it's okay. Right, thank you. Well, just to give you now, since it was very easy for me as professor requested me to give my journey in the surgical field, how I developed, what I could do, and how much I did, which after listening to the innovative orations, it is not great, but I myself am very satisfied and happy person now to look back in my country what my young colleagues are doing after I left the institution. Well, this small photo of my village where I was born and brought up, and only at the age of 9 years I was able to go to school. Why? Because distance of the school was far away. So we were underdeveloped country, and poor in the villages, no facilities for schools and hospitals. So walking for more than 1 hour to go to steep way top to the school, whole day study well with determination that we had no educated people much there, and we didn't have facilities on health and education and in the district there, whole country that way. So I had some kind of determination that I must do something. Then walking every day up and down and learning in the school with determination and interest and good intention to do something later on was such a blessing to me to develop my mental and physical strength, which I thank very much that situation, that village where I was born. I wasn't born in a rich family, big with a lot of facilities, going to school by car, That way I wouldn't have been what I am now. So this is the house from where I studied primary school. And after doing well in the primary school, our government needed people to study further in outside school. So I was selected to go to Kalimpong school, where I did my higher secondary examination and qualified in that. At that time, in class 10, I was a very good math student. So my teachers used to say that, oh, Sonam will be a good engineer. So my ambition became just to become engineer without knowing what is engineering. But the turning point was, when I was in class 10, my grandmother died in this village, in the same house, so I had to go back. That time for the rituals. And my great-grandfather was in severe pain, which I knew later that it was the fractured neck of the femur. So I wanted to do something. Next day, I went to the small dispensary there, which, in this dispensary, there were just no facilities and admission, anything, only one compounder from neighboring state. So I approached him. That my grandfather needs some medicine for his pain, and he helped me. And the poor compounder, he himself was not well, and he asked me to see the cupboard on the other room and see what I can get medicine. And mind you, as soon as I opened the cupboard doors, I found 3 platforms on the cupboard. In the middle, there was one tablet. You can't believe me, but I'm vivid with my memory. The tablet was written MB. Later on I realized it was Main Baker, and it was a sulfur tablet, which used to work for headache, fever, diarrhea, and also for the wound when you break the powder. So that was so surprising to me, and I took a crucial decision that time. Now what's the point of becoming engineer when I cannot help poor suffering people in the country. Let me be a doctor. And that was a crucial time for me in my whole life. Then after going back to the school as a first class student in maths and the class, I gave up maths totally, took optional biology, which used to take for scoring more marks in the final exam. And my maths teacher was very mad to me, that said I am a pagal, a pagal. But nonetheless, couldn't explain to him, but I had my aim and wish to do something for the community and the country. Then after that, I took the decision to become doctor. Then that decision was very crucial to me. And I completed the higher secondary. Luckily, I graduated quite well and I got Indian government scholarship to go to Indian Medical College. Because those days are few candidates, so I was one of the luckiest one. Got into Usmania Medical College, Hyderabad, where I could learn so many things in my life, in my journey, that college taught me how to become better students, how to learn subject better, because of my friends from there were so helpful. And my quality of reading, quality of doing things, plus sports, all improved further. Then after finishing MBBS in 1974, then I went back to Bhutan, started working from 1975. And for 4 years of general duty medical officer, it used to be said, you had to do indoor duty, outdoor duty. Luckily, that time there was a setup of surgical ward, medical ward, and gynae ward, and emergency. In this 4, we had to do duty, and we had 2 more medical officers with me, turn by turn, to do the emergency and all. It was such a great experience. Then we had to go out to remote villages where we had to conduct deliveries, where we had to see patients of all kinds, like retention of urine or any problem. But the problem was remote areas, getting them to hospital was difficult, but whatever possible way we used to do in the village. So there, I must tell you one little successful story, that once one of the village remote area where I had to work from the roadside more than 7 hours during winter, snowfall, houses covered with snow, and from evening 4 o'clock reached to the house by 12:31 in the night, where they were waiting for us because there was no phone communication, etc., but they were expecting us. Went inside. In Bhutan, we used to have village house, ground floor animals, first floor people with kitchen and living room. I had tea and all, went to see the patient. A lady, young lady of hardly 20, 25. There was, she was looking pale, and the case was intrauterine death more than 3-4 days. That was really surprising to me how to deal with it, because though I had my obstetric experience to some extent, I checked slowly. Luckily, I found the cervix dilated because the baby was trying to come out with natural expulsion. So slowly I managed to remove the baby out, small baby, and the placenta slowly delivered with a fear that she might get postpartum hemorrhage. And to my surprise, there was not much of bleeding, but could remove placenta successfully. But I was worried after going to sleep for few hours. I couldn't sleep because I knew, to me, very good surgeon, and he used to do general surgery and also orthopedic surgery, which he gave me a lot of lessons, and I could learn and experience many things with him. But the problem was, people were dying of late appendicitis operation and complications, which touched me very badly. Then again I decided, why not I become a surgeon, because there is nobody in the country, no surgeon in the country of our own. So I thought, let me do it. I think I can do it. So luckily, after doing some entrance exam among our 3-4 colleagues, I got a chance to go to do general surgery. But our government that time, I was quite influential doctor, educated, so they wanted me to go to USA to do fellowship in surgery. That is right from the world filming down to the authorities. I went there to Boston Mass General Hospital, where I had a great chance to follow their system. Not only the system and surgery, I was not assisting but observing only the system and the arrangement and the facilities. which I can't copy in Bhutan, but I have to take at least some micro amount of that. So that way, I continued. Now, my aim was to do fellowship in surgery, but that time, unfortunately, VQMD came up, ECF MG was not enough. So I had to wait for that for 1 more year. So I requested my country and came back to India to appear the entrance exam. Luckily, I landed up to All India Institute of Medical Science, which is a prestigious institute all over best all over the world, I'm saying, because of my experience there, learning there. And there, I not only learned the general surgery, system was so good, but you have to work day and night. And I had the determination and power. I managed to do the job nicely throughout and also learn orthopedic surgery, neurosurgery, pediatric surgery, and emergency surgery. These things really equipped me very well to be prepared to come back to Bhutan and do the necessary job for the people who needed all this. So after completing this MS, when I came back to Bhutan to start surgery, first as a junior surgeon, started doing many surgeries, which I know difficult ones. Most of the cases come late from remote areas and more difficult cases. But it taught me a lot of lessons, how to deal with them, how to take care of them. And of course, this photo just shown that to show young enthusiastic man with full of hair, that time. Now, of course, and I'm a very fulfilled man and happy. So after that, the thing keeps on going. When I was operating gastrointestinal surgery, biliary, urology, the problem was of diagnostic facilities. Good radiologists. One diploma radiologist was there. He used to do hardly contrast studies of barium and oral cholesterol those days for gallstones and biliary. And no IVU, which was not very satisfactory for renal. So again, I thought we have to have some people to do all these things, because government, at the expenses of government, these patients for simple ultrasound or endoscopy, we used to send to Calcutta on all government expenses, not only for the patient, patient's attendant, their food and loss, and treatment. After they go there, when the diagnosis is confirmed, they get operated there only and come back with a budget to pay for the patients outside. We didn't have much money that time. So I again felt that, why not we start ourselves? Ultrasound, endoscopy, and the cystoscopy, the good investigation facilities, which I had learned a bit in AIMS, but I went to do again in the same place. Luckily, they accepted me very easily and kept me in the compound. And 6 months, I did all three with dedicated determination, and also at the same time visiting the operation theaters, because I had easy access in that place. It was my parent institute. So going back, it made my job much easier, because gallstones I could easily diagnose with ultrasound myself in the morning, and stomach ulcers, cancers I could detect by endoscopy myself. Then further, it was much easier to decide what surgery to do, because before, if we are in a dilemma, laparoscopy was the only diagnostic facility apart from simple radiological procedures. It gave me immense pleasure and satisfaction, and patient care was better, and results were much better. Then later on, at the challenge news, opportunities we have to make and comes. So after doing all these cases, surgery and all, I used to do urology those days. People before in Bhutan, STD was very common, and there were many cases of stricture urethra and bad stricture urethra. Some prostate, BPS are also much easier to do surgery, but stricture urethra of many years was so terrible. I don't know how people survived without renal failure of obstructive uropathy. And those became a challenge. Then that gave me another scope to look for doing some more in the urological field. So that time I approached the government, quite influential those days, so they easily accepted my still there. And to remind you, emergency unit was the 2 rooms, and there were minor OT, and the ward with 8 beds. So that used to be a good place for us to carry on and taking care of the people. Then the need comes despite odds. We always have to go forward. And laparoscopy, which I was very keen, because German chances to expose in this. Plus in AIMS, my colleague, Dr. Professor Misra, he was the HOD, and he used to invite me most of the time for this. You know, we had ELSA, that endoscopy, laparoscopy surgery. There in the program, I used to be there for 2-3 weeks, learn laparoscopy, just surgery, and go back. Then very keen to start this, but the lack of budget in the country was a problem. So, but the coronation time of our fourth beloved king, I got a good chance. Government wanted me to do something more in health development. That was the time I could took the opportunity and got the budget to start laparoscopy. Then I must tell you now how to go about. Myself with 2 nurse brothers make a team, and we ordered some Philips laparoscope machine, and WHO helped us to give this Wolf endoscope of 13 millimeter, quite a big one. Nonetheless, there's something to start. Then I went to Mumbai, Ethicon Johnson Johnson, with the help of my friend Mr. Rakesh, who used to deal with healthcare associates and supplied equipment to us. Killed 4 or 5 pigs to get hand on how to do laparoscopic cholecystectomy. Then that gave me some confidence, and came to Kolkata, where my colleague arranged with Dr. Om Tantil, where he used to do a lot of laparoscopy those days, and charity for poor people, just charging 5,000. And there, after seeing him do it for 1 week, 10 days, my brothers making them understand the equipment, sterilization, procedures, arrangement, all. We came back to Bhutan in 1999, before the coronation silver jubilee of our beloved king. We set up things ready for inauguration. And it was a great opportunity. Started laparoscopy that time, and after that I never looked back. And I passed these experiences to my junior colleagues, which I'll tell you afterwards. One of them was the ex-Prime Minister of Bhutan. Then they have continued further. That was a great opportunity for me to do something new in the laparoscopy, though nowadays this robot coming and advance going on. But for me that time it was a great invention and great support to do difficult cases by laparoscope. So that helped me a lot. And just to show you, this was the ward on the left side, surgical ward and medical ward, and we had private ward, and I developed isolation and post-surgical cases ward, and I developed operation theater. You know, the new building at the corner up there, high building, in that there was a 1-story operation theater where I started my surgery and laparoscopy. It's no more now, but big hospital has come up from 2003, where new instruments, gadgets, and my colleagues coming up, it has really developed further. Just to show you that. Now, on the side there, you can, sorry. Can you make a big one, this one? And second is our ex-Prime Minister, who was the surgeon first. After seeing me, he went to do surgiscopy, and he's a good surgeon. He did a lot of surgery, and in fact, he went beyond my work, that went to villages, running camps in remote areas high up in the mountain area where electricity was problem, but still he managed to do a lot of cases. And he's now governor of the Kelefu Mindfulness City, where under present king, he is working hard to develop that mindfulness city project. So he still does surgery time to time in the regional hospital in Kelefu. It is so pleasing to see that they come up soon and continue neurology, and he is the HOD of the General Hospital, Thimphu, where a lot of work done, and even the residency. This gives me immense satisfaction, and how I passed on to my junior. They're doing much better than what I used to do. Then, you see, this sort of experiences to gain, to perform as a human being like you, and maybe like your relatives, we have to have the feeling, what you do on them, not for the sake of just operating, for the sake of relieving their pain, relieving their suffering, and healing them. That intention every surgeon should have in mind. so we can achieve success as far possible as possible. So then I got chance to again go to Germany, aims to further, enrich myself with experienced people and learn more and pass on to my colleagues, which I could manage to do it by my influence with my friends who sponsor me. I mean to say that there's not only money, but colleagues can help you. So that way, as Professor Khanna said, he has gone to so many places and done, we can always find out. But these people used to come to Bhutan as tourists, doctors, and they want to help. They're rich people. When they want to help us, we have to take that opportunity and utilize it and share with our colleagues and the country for their progress and patient. So now in our medical university, we started medical college in 2008. I hope I'm on time. 2008, where surgical, medical specialty we started. Later on, spread to orthopedic, anesthesia, eye, pediatrics. So we are very happy that from 2008 to now, we have produced a lot of medical graduates, MBBS graduates in our country. And further, they are sent out for specialization. So today, you see, oh, 1 minute. Can you make it bigger? Oh, you can see the Bhutan map that side. Can it be bigger? Next. No, the same. A. Bada also? No. The Bhutan map, you can see it's a small country. Now, we have all those red spots are health centers. Previously, from all around the country, they used to come to the main Thimphu General Hospital, which was the only general hospital with surgical facility. Other places, no surgical facility, no emergency facility, only first aid and the simple treatment. Now, from that center, one where I used to operate people from all around, there are already over 12 centers which are doing laparoscopy surgery and with surgical facilities of a surgeon, anesthetist. And anesthesia was another problem with us, but we got it somehow trained now, and we have enough anesthetic. Enough means for the localities. And my one success story, two success stories I must tell you in pediatric surgery. We didn't have pediatric surgeon. Well, in late 90s, the two cases which I can remember is that one child, 10 days old, small like a monkey, and the problem was vomiting, congenital pylori stenosis. So parents brought from far, little, malnourished, dehydrated, electrolyte imbalance. So I had to talk to them. This child has got obstruction, but surgery is needed. There's no other treatment, but I can't expect what will happen to him after surgery because we had to give him anesthesia. We didn't have pediatric anesthesia. So parents agreed, whatever happens, please do what is best. So I had to do the surgery, and anesthetist intubate, after intubation of the child, he could not extubate because child could not respond to the reversal. So that night, it was a night time, me and the nurse anesthetist, whole night we were bagging with umbo bag those days. No ventilator, no incubator. No, there was one incubator, old one, donated by some some organization. We managed to bag the child throughout night. Next day, after 8 o'clock, the child could be reversed. I was so satisfied, happy, gave the news to the parents. Then later on, this child, after 16 years, came to meet me in my private center where I'm working now. Grown up, young, handsome boy in class 9. And I was so thrilled and happy, which I cannot explain to you, but I had enough of happy hormones released in me. So that makes my life much better and younger, I think. So that is one experience. Other one was, a child was brought 10 days old in almost like asphyxia, child not able to breathe properly, a lot of, imbalance of electrolyte and oxygen. It was almost the child is going to die. In the emergency, I had to see. They had to talk to the parents. But diagnosis we could make out, the X-ray done, and ultrasound I did. The bowel, all the bowels were in the chest. Diaphragmatic hernia, content all gone up, and child was like almost to a dying stage. So I had to talk to the parents. Now, there's nothing else other than surgery, but can't guarantee to save the child. And the parents agree. This important thing is communication to the patients and your intention to do something to heal that child or patient. So they agreed, whatever happens, sir, please do what is best. We don't mind if the child dies also. Then it gave me some good confidence. Then that time I was worried about anesthetist. But I was lucky that one anesthetist, pediatrics anesthetist came back after from, I think it was from Sri Lanka. Then she gave good anesthesia, and I could operate the child, bring out the contents of the abdomen, put the, close the hernia, then put a mesh. And to my surprise, that child could be kept alive throughout the operation and extol. Then child was doing well, SpO2 improving quite well. Then I went to thank that anesthetist. You did so good job. I was never satisfied with anesthetist in pediatric surgery because I used to do hair, lip, palate and all. That's a lot of problem. So she told, sir, you don't know me? I said, yeah, you are anesthetist. I'm your precious child. I got scared also. What does it mean? Sir, in 1976, or 75, you delivered me from my mother. Those days we used to do delivery. Oh my goodness, it was such a great thing to know about that. So these were some success stories which I remember and I'm telling you. And that is very fulfilling on my journey to do something and to be satisfied. Now, there were never a moment of where I looked back. Then you have to carry on shifting the gears. Sometimes I feel like I'm an auto gear, like flying pilot. Then I'm so honored to share these stories of my experiences, my challenges with all of you. And the road forward is as clear as your intentions are, and the light on the road remains as long as you are determined and disciplined to do something good for the patient. So future is in your hands, and what you make it of it and how it defines you depends on your promise to yourself and your conviction to keeping the promise. Now, with this much, I wish you all the best. Please carry on further. There is no end to doing and finding out something new to carry on, like this microchips and capsule robotic, which I never expected is coming up. So I wish you all the best, and it's a great privilege for me to be with you all. And please continue to learn and grow. One day you will make definitely a difference, not only to the people, to yourself. So that is the great satisfaction in life, what you can do, what you should look forward. So thank you very much. In our Bhutanese, we say Tashidile. And I must say, Professor Anubhav Sonkar, who came to Bhutan for a few days, but it was so wonderful being with him, not only in our academic laparoscopy surgery, also evening cultural program. So it was a great pleasure. And I again thank you, Professor Abhinav Sankar, and the organizing committee for giving me this great opportunity to see Lucknow and your university, which during my studies in AIMS I wanted to come here, but never got chance. So thank you so much.
Thank you, sir. Thank you, sir. Your story was highly inspirational, and personally I am deeply impressed with your story because of few reasons. Number one, the humble background from which you started your own journey. Initially, what we have seen that you did not have the means to start your education at the correct age. But from there, you have risen to a level and stature that today you have delivered the oration in one of the most prestigious departments of surgery, in the entire India. This is your level and this is what you have done in your life. Second, you started the establishment of medical facilities in general and surgical facilities in particular in a country where there was nothing. Very few people in this audience would understand that when there is nothing in a country and there is dearth of all the facilities and a poor country which does not have the facilities and money power to establish the medical facilities, it is so very difficult. Not only that, you established medicine, but in surgical side also, practically established all the surgical specialties like general surgery, laparoscopic surgery, like urology, pediatric surgery, even you touched obstetrics and gynecology. For that reason, I think you are the best person to deliver this oration because it was the duration of the headship of Professor P.C. Dubey that all the super specialty departments which you see in KGMU today, they started during his time. He initiated, he foreseen all these departments and he started that. Number three, a small request from my side. We have a community radio station in this KGMU, which is the only radio station, community radio station, which is owned and run by an exclusive medical institution in India. We prepare success stories of people whose footsteps can impress other people or who inspire other people. I will ask my team, they will come to you today. Please spare some time. They will make a program and we will broadcast it quite frequently. Thank you, sir.
Yes, a few comments more. Thank you, Dr. Sonam. Excellent presentation. Unplanned journey, but missions achieved. You have reached all the destination. You have been really a basic doctor from the government, yeah, as a physician, family physician, general surgeon, and a specialist surgeon. My congratulations to you for this impressive and very astonishing lecture. Thank you.
The speaker's facilitation will happen at the time of the inaugural ceremony.
Thank you, sir, for such an inspiring talk. Your journey has indeed left us motivated and enriched. I would now like to request Dr. K.K. Singh, sir, to kindly felicitate Dr. Bharat Dubey, sir. Thank you, sir. Finally, to conclude this session, we now have the Professor T.C. Goel guest lecture, for which I would like to request Dr. Diwakar Dalela, sir. Dr. Diwakar Dalela, sir, is a former head of Department of Urology, KGMU, and is a prominent urologist and a renowned teacher. Sir, I would like to request Diwakar, sir, to kindly join us on the dais. Next, I would like to invite Dr. Apul Goel, sir, who is a professor and head of Department of Urology, KGMU, and is son of Professor T.C. Goel, sir. His field of interest are endourology, reconstructive urology, female urology, and is a renowned surgeon and academician. Sir, I would like to request Professor. Thank you, sir. Next, I would like to request Dr. Sandeep Verma, sir, who is a former faculty of surgery at KGMU Lucknow and is founder director of AIMS Bhopal. He has extensive experience in surgical oncology and breast diseases.
Hello. So it's my privilege to introduce the honorable speaker at the present moment, Professor Bhavanta Dilshan Gamage. He is a professor of surgery, University of Jayawardena, Sri Lanka, President-elect, College of Surgeons of Sri Lanka, Founder President, Sri Lanka Association of Minimal Access and Digital Surgeons, a specialist general surgeon with focus on laparoscopic colorectal, adrenal, gallbladder and hernia surgery, Secretary General, SAG Surgical Care Society, former head, Department of Surgery, University of Sri Jayawardena. He has delivered multiple prestigious national and international orations in last many years. He has contributed and edited number of surgical textbooks on especially GI bleeding guidelines. He is a profound researcher. He has published extensively in indexed and Google Scholar ResearchGates. He is a team leader for BMJ South Asia Best Surgical Award for ERAS implementation in resource limiting setting. Welcome Dr. Gamage to King George Medical University, and you are here for your lecture.
Thank you very much for your kind introduction, sir. Son of Emeritus Professor T.C. Goel, Dr. Apul Goel, consultant urologist, distinguished guests, post and undergraduates, ladies and gentlemen. Good morning to all of you. First and foremost, I wish to extend my sincere gratitude to the Dean, Vice Chancellor, Professor of Surgery of the KGMU, Professor Sonka, and the academic staff of the King George Medical University for inviting me to deliver this prestigious Professor T.C. Goel oration for the year 2026 at the 114th Foundation Day of the Department of Surgery. The topic is impact of gut microbiome in colorectal and surgery and surgical outcomes. I consider this as a great privilege to bestowed upon me to honor an eminent surgeon, a teacher, academic, and above all, a humble human being, the Emeritus Professor of Surgery, Trilok Chandra Goel, by delivering this oration this year. Born in 3rd October 1938, comes from a small town called Danko in Uttar Pradesh. He came to KGMC, Lucknow, to study and got through in 1962. He stood first and was awarded 14 gold medals, including the prestigious Hewett Medal, 2 silver and 1 bronze medal, 2 book prizes and honors, and chancellor and writing from the beginning of his career. He has published microbiome that is causing the aggressiveness. Microbiome that is causing the aggressiveness. Mr. Chairman, what is the pathology behind colorectal cancer and inflammatory bowel disease? When the pathogenic organisms produce these abnormal metabolites, it causes chronic exposure. The host tissues leads to chronic inflammation, and it triggers the immune system in our body, leading to inflammatory bowel disease. Also, the long-standing exposure to these abnormal metabolites causes mutations in the gut mucosa, leading to colorectal cancer. I want you to have an understanding about this terminology, dysbiosis. Dysbiosis is a term used to describe the imbalance of microbiome, and dysbiosis has clearly shown to influence the development of many diseases, including colorectal cancer and inflammatory bowel disease. Bacterium fragilis, along with species such as Fusobacterium nucleatum, were shown to be overabundant in patients with colorectal cancer. Across the many geographical locations, including Europe, America, and China. They have also found higher abundance of fusobacterium species in adenomas, which are pre-malignant conditions for colorectal cancer. This study was done using South African population, and they have got healthy microbiome, which produces much more short-chain fatty acids, which improves the gut health and reduce the inflammation, as I told you, compared to the European population. Rural Africans eat legumes, grains, which are high in fiber, whereas Europeans eat processed food, meats, red meats, and dairy products, which are high in sugar. When compared the gut microbiome of these two groups, it has been shown that in Africans and Europeans, there's significant change in their gut microbiome. But ladies and gentlemen, most of these studies which I have quoted are done in Europe, and we do not have our own data. Therefore, I was listening to a talk in microbiome in Turkey in 2016 in one of the surgical conferences and thought that we should study this in our country. So I came back and started study with our immunology department in 2017, and aim was to characterize the stools and tissue microbiome in our cohort of patients. So we studied colorectal cancer patients, patients with pre-malignant lesions, patients with diabetes who have not got colorectal cancer, and healthy controls. So the study is this, which was published in BMC Cancer in 2024. We did metagenomic analysis of colonic tissue and stool microbiome in patients with colorectal cancer in South Asian population in Sri Lanka. I'm going to go into a immunological jargon. Don't worry, I will explain that in more simpler terms. So what we did was, the gut microbiome was assessed by 16S metagenomic sequencing, targeting V4 hypervariable region of the bacterial 16S rRNA in stool and colonic tissue samples. What does that terminology mean to you? What is metagenome? Metagenome is consists of all the organisms found inside the gut. When we were medical students, the organisms were identified by culturing them in culture media. If the organism is not cultured in that particular media, we did not identify them. But with the development of immunology, now we know there are much more organisms which can be identified by a technique called genomic sequencing. So if you sequence 16S rRNA in the gut, you will identify the fungi. In the same way, if you do 16S metagenomic analysis or sequencing, that can isolate fungi and bacteria. So this technique is used to study the diversity of bacteria in a sample by sequencing 16S ribosomal RNA. Now, where is this ribosomal 16S rRNA? It is in the smaller subunit of the microbial ribosomes. So 16S metagenomic analysis is a powerful tool for studying microbiome. And it can be used to track the changes of the microbiome over a period of time. If you look at the 16S rRNA gene more closely, it has got conserved regions, which are marked in white, and variable regions, which are marked in gray, V1 to V9. So 16S rRNA gene is very similar in all bacteria, while the variable regions are more variable between species. So the hypervariable regions are the most variable regions of the 16S rRNA gene, and they are often used to distinguish between closely related bacterial species. So there are 9 hypervariable regions in the 16S rRNA gene, named 1 to 9 here. And we used V4 hypervariable region for our genomic analysis. So let me come back to the paper again. That is why I said the gut microbiome was assessed by 16S metagenomic sequencing targeting V4 hypervariable region of the bacterial 16S rRNA in colonic tissues and stool samples. So that is the terminological jargon I used. So our study cohort consists of 112 patients. Out of that, 50 were healthy, and there were 28 patients with diabetes who have not got colorectal cancer, 24 patients with colorectal cancer, and 10 patients with pre-malignant conditions. This is an expensive study in 2017 and 18 because we had to send all the samples to USA for sequencing. But now I am happy our immunology center has all these facilities for sequencing. That is why we had to limit our study cohort. There are two terminologies I want you to understand to discuss further this subject: richness and diversity. So if you look at the top left-hand corner, if you see one color is one microbial species, there are 6 microbial species on this side, and it has richness. That means the number of microbial species are more compared to the right lower the slide, which has only got 2 species, so it has lower in richness. What does diversity means? Diversity is a comprehensive word, and it includes both richness and the evenly distribution of its abundance. So the first one has higher the richness as well as the diversity. What is the clinical importance? If your microbiome is rich and diverse, it is better. And it has been known that reduced richness and diversity increase the risk of inflammatory bowel disease, increase the risk of colorectal cancer, and more importantly for us, it has been shown that it causes poor recovery after surgery. So we analyzed our data, and the results we found was quite alarming. In stool samples, in our 112 patients, dominant phyla across all groups were firmicutes, bacteroids, proteobacteria, acetobacteria. And in colorectal cancer patients, it showed higher proportion of bacteroids compared to healthy and pre-malignant patients. Then pre-malignant stools had higher firmicutes compared to healthy and colorectal cancers. And we have observed there is a significant difference in the microbiome of the pre-malignant and healthy individuals, and it shows distinct microbial shift even at the phylum level in colorectal cancer patients and pre-malignant groups. How about the tissue levels? In the tissue levels, colorectal cancer tissue had higher abundance of bacteroids, and healthy tissues had higher abundance of firmicutes. So this indicates that there's distinct microbial shift in colorectal cancer tissues compared to the healthy colonic tissues. We also observed there's overabundance of certain microbes in stool samples of pre-malignant lesions. Therefore, there is a potential to develop biomarker in future to identify patients with pre-malignant conditions. What have we got to know from this study? Despite the dietary differences in Sri Lanka, the colorectal cancer microbiome mirrors the Western cohorts. Bacteroides fragilis and Fusobacterium are common in both geographical locations in patients with colorectal cancer. What are the clinical implications? There is a potential for dietary intervention in prevention, and more species level studies need to be done to determine a biomarker to diagnose pre-malignant lesions. And more importantly, ladies and gentlemen, this study, first from the Sri Lanka, contributes to the global South Asian data on microbiome. What about the future? Future is optimistic. Can we modulate the microbiome to use in therapeutics. Ladies and gentlemen, we all know our blood groups, but do we know a genomic profile of our microbiome? In Western world, they do genomic profiling. And clinical trials are on how to use probiotics, prebiotics, and what are the durations that we need to use them to have a therapeutic effect. What about the fecal microbiota transplantation, which can change the dysbiosis of the microbiome to create a healthy environment inside us? And it has been used in clinical practice to treat certain conditions. So to change the microbiome profile, fecal microbiota transplantation can be used. And in colorectal cancer mouse models in the laboratories, fecal microbiota transplantation from healthy donors reversed the severity of gut microbial dysbiosis. And fecal microbiota transplantation has reduced the tumor size and the number in laboratories. It increased infiltration of anti-cancer immune cells like CD8 cells, natural killer cells in tumors. It upregulates the anti-tumor mediators like tumor necrosis factor alpha and interferon gammas. No, immunotherapy has revolutionized the cancer treatment. Is there a place played by microbiome? The immunotherapeutic agents work very well in some people, but they don't work well in others. What is the reason? PD-1 and PD-1 ligand blockers are commonly used immunotherapeutic agents that have revolutionized cancer treatment. Microbiome plays a role there. Microbiome-free mice in the laboratories did not respond to PD-1 blockers at all. So when they do fecal microbiota transplantation and probiotics and change the microbiome in the gut of these mice, they start responding. So therefore, there are evidence coming up that microbiome plays a role, huge role in immunotherapy. This is for us, all surgeons. Is there any role played by gut microbiome for post-operative adhesion formation, post-operative paralytic ileus, anastomotic leakage? Mr. Chairman, people compare aviation industry and surgery because both expose us to high risk or people to high risk environment. But if there's a catastrophe in aviation industry, they do what is known as root cause analysis. If we have a surgical catastrophe, if a patient dies, for example, after an anastomotic leakage, do we do a root cause analysis? I don't think. Of course, we do morbidity mortality, and in them we discuss these patients. We say this patient had an anastomotic leak. We did not rectify it in due course, therefore this patient died. But then we explain this patient has got low albumin level, low hemoglobin level, and it is the patient after radiotherapy, therefore anastomosis did not heal. But if you compare all the high-risk patients that we have done anastomosis, most of them healed well. On the other hand, the young, fit patients whose albumin levels are very good, hemoglobin is up to the expected levels, their anastomosis also leaked in some of them. Why? Is there a place played by microbiome? Now, this is a very fantastic article published in International Journal of Colorectal Surgery in 2009. It clearly said surgeons lack the predictive accuracy for anastomotic leakage in gastrointestinal surgery. Mind you, this is published in 2009 when the understanding of gut microbiome was not that great. Now, what about post-operative adhesions and paralytic ileus? Now, this systematic review tells that the certain metabolites produced by this gut microbiome crosses the gut mucosa and acts on the submucosal nervous plexus and causes paralytic ileus. That is why in certain people, even if you do the same surgery, same duration by the same team of people, some people develop paralytic ileus, some people develop adhesions. And we have tried many ways to minimize adhesion formation without many success. This is a professor of surgery from Chicago, John C. Alverdi, has done extensive studies on this subject, and we have learned a lot from him. And he has categorically said there is uncontestable and unambiguous evidence that bacteria at the site of anastomosis play a significant role for anastomotic leakage causation. So, ladies and gentlemen, can we prevent these anastomotic leakages, or can we minimize them? What can we do to reduce the anastomotic leakage? First thing, we can get rid of harmful bacteria. The second thing, we can restore the bacteria, the good healthy microbiome as soon as possible. The third strategy is to block the action of harmful products that are produced by the microbiome. So how can we get rid of harmful bacteria? Preoperative bowel preparation. Now in 2007 to 2009, I was in Colchester doing my colorectal laparoscopic fellowship. During this period, enhanced recovery protocol came into practice like a storm in entire Europe. And I was heavily involved in implementing that in UK. And then I brought back that concept into Sri Lanka in 2009 and has implemented a modified version of enhanced recovery in Sri Lanka. And this, at that time, people started operating left colon and rectal cancers without oral mechanical bowel preparation. And this fantastic meta-analysis was published by Dilip Lobo's team from Nottinghamshire and showed even if you give oral mechanical bowel preparation or not, what they used is enemas, phosphate enemas for rectal cancers and left colonic resection. There's no significant difference in anastomotic leakage, no significant difference in intra-abdominal collections and surgical site infections. Then around 2015, this study came and consensus was made. If you're operating on colorectal cancers, you should use oral mechanical bowel preparation, but it has to be combined with oral antibiotics. So what is the difference? If you do that, anastomotic leakage reduced, intra-abdominal corrections reduced, surgical site infections were reduced. So the important thing is antibiotics. How do we rest? Now in my unit, in Colombo South Teaching Hospital, when we do left colon and rectal cancer resection, we don't use oral mechanical bowel preparation. But we do use phosphate enemas and also combine oral antibiotics. The recommended antibiotic is metronidazole and neomycin. But in my unit, since in Sri Lanka we don't have neomycin, unfortunately, so we use metronidazole and clindamycin, which is also recommended. And our anastomotic leak rates are comparable to the published data, and we have published this in international journals. So the second strategy is restore the microbiome as soon as possible after surgery, and this is the basics of enhanced recovery program. When Henry Keel introduced this in 1997, he published his first article in British Journal of Anesthesiology. I met him in 2018 in one of the conferences. And he said to give your patients to eat and drink as soon as possible, provided there's no post-operative nausea and vomiting. And he did not recommend to use opioids as analgesics. And the papers are coming up that morphine promotes colonization of anastomotic tissue with collagenase-producing bacteria, which can increase the anastomotic leakage. So as I told you, we started practicing this enhanced recovery protocol, modified in Sri Lanka in 2009. And with a lot of hardships, in 2018, it took nearly 5 years for us to achieve this target. And in 2018, we published this in British BMJ Award, South Asia, conducted in Chennai, and we won the best surgical team of the year for successful implementation of enhanced recovery, modified enhanced recovery program in our part of the world. in Sri Lanka. So can we block the third strategy to minimize anastomotic leakage? Can we block the action of these abnormal metabolites which increase the anastomotic leakage? Studies are going on, and tranexamic acid is being used in the laboratories to block the action of collagenase producing bacteria and the metabolites produced by them. And it has been a success story. So the results will come up in near future. So, Mr. President, Chairman, ladies and gentlemen, I have taken most of you to uncharted territory in the surgical field. And there are many things to explore in this fascinating field of microbiome. So in conclusion, the gut microbiome diversity and the types of species present can enhance or can cause the increased susceptibility to colorectal cancer and possibly progression. We know the gut microbiome diversity and the types of species present do affect the susceptibility to colorectal cancer. And the thing is, can we manipulate the gut microbiome to prevent colorectal cancer in our cohort of people? Probiotics, how long should we use? What are the recommended durations? And fecal microbiota transplantations. Trials are there in Western countries. Should we consider that in our part of the world? And what are the pros and cons? So these are the things to study. And also, can we use certain microbiome species to as diagnostic criteria, especially pre-malignant lesions? And alteration of gut microbiome, this is well proven now, to reduce the anastomotic leaks. With that, I conclude the TZ Goal Oration for 2026, and let me invite all of you to attend to our annual surgical congress this year in Colombo in September 2nd to 5th. If you haven't visited Sri Lanka, it's a beautiful country with a lot of natural beauty and the wildlife. Please do visit. Thank you very much.
Thank you, Professor Bhavantha, for this wonderful presentation. You, as you mentioned in your, at the start of your presentation, it's an uncharted territory. Most of us are not aware of microbiomes and the role that they play in various diseases. As a urologist, I must say that even the urinary bladder, we talk about microbiome existing. You know, a sterile urinary culture may not be sterile actually, because the typical growth doesn't happen, but we are not looking at the microbiome. And you mentioned about chronic kidney disease in one of the slides, you know, the role of microbiome in that chronic kidney disease. But there's a condition called interstitial cystitis, where, you know, the cultures are repeatedly sterile, but the patient suffers from dysuria and other things. So maybe there's a role of microbiome in that particular condition. So thank you so much, and before we wind up, I'll thank Professor Sonkar and the Department of Surgery for organizing this lecture in the name of my father, and it's a matter of pride and privilege for me to chair this session. Thank you so much.
Thank you, Dr. Gamage, for the nice talk. Yeah, I'll just take as extension of what you spoke in this morning, is about the restoring gut microbiome and the ways that we do in our Indian system. The probiotics are the ones which you said live gut bacteria that you take and restore the GI population. But the problem with the probiotics is that the shelf life of the capsules that we get is very limited. So the patient will buy the capsule, and if they keep for about 5 days, 7 days, 1 month in room temperature, they get destroyed.
Yes.
So we as the Indians have been used to using prebiotics.
Yeah.
Prebiotics means the sources in the diet which nourish the gut microbiome.
Yes,
which is a more logical thing. And I'm sure you know that in our diet we consume lots of fermented food. Fermented food gives you a source of bacteria, probiotics, and in our diet we consume such fibers, which are the food for microbiome.
Prebiotics, yes.
Right. And I want to share you one yoga practice that when you sleep overnight, you create fermentation in your mouth, oral cavity. And as a result of fermentation, a number of microbiome grow in the oral cavity. And when you get up in the morning, first thing you should do is to drink water. And drink water not like gut. Jal khavo, you know? Sip by sip in the mouth, let it go, and then you gulp the water. The whole idea is whatever healthy bacteria you have created by the fermentation in the mouth in night, you take them back in the gut and you restore the gut microbiome rather than brushing the teeth in the morning. So this is called Usha Pan. I don't know how many of you know this. This is called Usha Pan in yoga practice. So there are many such practices in our country or in humanity which restore the gut microbiome. And another thing I want to share with my recent knowledge is about inulin. You mentioned inulin in your talk. Inulin is a prebiotic. And the richest source of inulin is garlic, onion. And you take this in our salads, asparagus, and kacha kela, raw banana. Entire South India takes, and I think in Sri Lanka also you take raw banana chips, raw banana in food. It is a rich source of inulin. Inulin you eat, it will go the esophagus, go to the stomach, not digested in the small bowel. It just goes as it is in the colon. And colon, it gives the supply for the microbacteria. So who knows, in future you will start recommending raw banana to a colon cancer patient.
It's a fascinating field to study, sir.
Fascinating field, yes. So friends, keep eating raw bananas and garlic and onion and asparagus, and don't brush your teeth in the morning as you get up. Drink glass of water first and then brush.
Thank you very much, Professor Bhavanta. This is nice and wonderful talk. Gut microbiome comes in the big way in the last 1 decade. But you can produce the South Asian data. That is the mirror image of the Western country. I think you must congratulate for this Asian data, basically. We must congratulate to all.
Exactly. We have started studying more widely in this subject now, so the results will follow. Thank you.
The speakers are felicitated in the inaugural program.
Thank you very much for giving me this opportunity again, Professor Sonka and the Department of Surgery. Thank you.
Thank you so much, sir, for such an insightful and engaging approach on this topic. Now, I would request Professor H.S. Pahwa, sir, to kindly felicitate Dr. Divakar Dalila, sir, Dr. Apul Goyal, sir, and Dr. S.K. Bharti, sir. Thank you, sir. So we will now be moving towards the ceremonial segment of our today's program. So may I request all dignitaries and members of the audience to kindly remain seated for a few minutes. We shall be resuming shortly.
A very good afternoon to all present. It is my proud privilege to welcome you all to the inaugural function of the 114th Foundation Day of the Department of General Surgery, King George's Medical University, Lucknow. Today, we gather not merely to commemorate a date, but to celebrate a legacy. 114 years of healing hands, pioneering minds, and unwavering dedication to patient care and surgical advancement. I extend a warm and heartfelt welcome to each one of you as we formally commence this momentous celebration. May I now request our esteemed dignitaries to kindly grace the stage. It is my honor to welcome our Honorable Pro Vice Chancellor, Professor Abhijit Kaur. Welcome our head of the department, Professor Abhinav Arun Sonkar, sir. We extend a floral welcome to sir. I now invite Professor K.K. Singh, sir, to the stage. We extend a floral welcome to sir. I welcome the organizing secretary of the event, Dr. Gitika Nanda, ma'am. We extend a floral welcome to ma'am.
Before we begin with the lighting of the lamp, I would like to take a moment to remember our revered teacher and eminent surgeon, Dr. M.S.D. Jaiswal, sir, who left for heavenly abode on the 8th of February 2026. Sir served as the head of the department from 1999 to 2006. He was widely recognized for his outstanding clinical expertise and mentoring generations of both undergraduate and postgraduate students. Beyond his professional accomplishments, he will be remembered for his humility, warmth, and the personal care that he extended to every patient and student. His legacy will continue to guide us and inspire us. May I request a moment of silence in his memory. May his soul rest in peace. Thank you.
The lighting of the ceremonial lamp symbolizes the triumph of knowledge over ignorance and reaffirms our commitment to discipline, compassion, and the ethical practice of surgery. On this auspicious occasion, I request all the dignitaries to kindly move forward for the lighting of the lamp. Thank you, everyone. I now have the honor of inviting Professor K.K. Singh, sir, Professor, Department of General Surgery, to deliver the welcome address. Sir is a skilled surgeon, a beloved teacher, and above all, a benevolent human being whose guidance has shaped generations of surgeons. Sir.
Good afternoon, everyone. It's my immense pleasure to welcome you all in the 114th Foundation Day of the prestigious Department of Surgery of KGMU. I warmly welcome our distinguished guests, especially Dr. Anil Goyal ji, whom I am meeting for a very long time, the other dignitaries on the dais, the Pro Vice Chancellor, CMS, Dean, my head of department, Dr. Geetika Nanda, and all others sitting in the audience, including my teachers. At the very onset, I extend my deep regards and gratitude to the founders of this great department. Their vision, dedication, and determination with which they laid the foundation of this department, which continues to guide and motivate us every day. I extend my heartfelt gratitude to all our distinguished orators and speakers who spared time for this event. Dear colleagues, ladies and gentlemen, it is often said that for any great achievement, a strong foundation is essential. The foundation becomes the platform upon which the future is built. Today, as we celebrate the 114th glorious years, we remember with pride the humble beginnings of this department and the remarkable journey that has brought to us where we stand today. Any Foundation Day is not merely a celebration of years gone by, it is a celebration and remembrance of the commitment, resilience, excellence, and continuous growth. More than a century ago, our founding leaders built up a vibrant and dynamic department of surgery. Through perseverance, academic rigor, and unwavering dedication, that vision has transformed into reality. Their foresight and hard work created this institution that has stood the test of time. This department has given birth to at least 10 super specialty departments in this institution. All of them were carved out from this parent department, and many of the luminary teachers shifted to the new super specialty department to create that department. But despite shifting of so many luminary teachers, this department never lost its shine, and for me, this is the greatest achievement of this department. Every Foundation Day gives us an opportunity to reflect to our beginnings, to acknowledge the milestones we have achieved, and to renew our commitment to excellence. It reminds us of the progress we have made and the responsibilities we carry forward. Our department not only produces academically accomplished graduates and postgraduates, but also nurtures their overall development. True education goes beyond textbooks and examination. It shapes character, ethics, and leadership. Today's MBBS students are the future of our state and nation. We try that they grow into skilled professionals, compassionate healers, and responsible citizens who uphold the highest human values. May they achieve success, recognition, and honor while contributing meaningfully to our society. In the end, on this auspicious day and occasion, let us all take and pledge to work earnestly for the continued growth and development of our department and our university in every dimension, academic, clinical, and research-oriented. We seek the blessings and guidance of all our seniors, teachers, founders, well-wishers, so that we may continue to move forward with strength and unity. Thank you.
Thank you, sir, for your kind words. Now I would like to felicitate our esteemed orator, Dr. Subhash Khanna sir, who delivered Professor S.C. Mishra oration, to please come forward to receive the memento as a token of our deep appreciation.
Sir, Professor Subhash Khanna has to leave early. He has to catch a very early flight. So we will only felicitate him and then we'll carry on with the rest of the business of the day.
Thank you, sir. I now invite our esteemed head of the department, Professor Abhinav Arun Sonkar, sir, to present the annual report. Sir exemplifies true leadership. His vision, dedication, and steadfast guidance has been instrumental in elevating the department to its present stature. It's a privilege to welcome you, sir.
Thank you, Ashna. A very good afternoon to all of you. I see my teachers, my colleagues, my dear seniors, people from the dais, Professor Dr. Anil Kumar Goyal, sir. He is 1975 batch alumnus, not many people would not be knowing it, and he is also honorable member of the Legislative Assembly of Delhi, and he represents Krishnanagar, accomplished urologist. Our Vice Chancellor, Professor Abjit Kaur, she needs no introduction. Our Dean, humble, sweet, Professor V. Adam, and Head of the Department of Medicine, Professor Oja, my immediate senior. I jokingly and mockingly call him my official father because he is my immediate senior. And he asked me to recite some literature also. I will not elaborate on it. Gitika ji, Professor K.K. Singh, Gitika ji, Organizing Secretary, Dr. Dalera sir, Dr. Khanna, Dr. Dukpa, and Dr. Gamange. It's been an other head of the department and the member of press. It's been really an honor and privilege to stand before you. Sir, you know, when Indian mentality is to have 2-3 things in life, education of kids, which we do, they are not our blood, but they are born from here. Then we also happy if we have good things in our house. And then good things in our house means good instruments and good things which we fancy. Surgeons fancy their fanciful toys or laparoscopic surgeries or whatever they think of themselves. And then lastly, a good house. So this year it's going to be a little different. It's been kind of a fruitful year. We celebrate this Foundation Day every year. When Professor S.C. Mishra, who returned from London, Professor, you must have seen him or you must have heard of him. He was trained in UK. He created a department where the pre-operative, operative suites were there, the offices were there, everything under one roof, and there was a high dependency unit, everything was envisaged during his time. So you can understand, it was given where we are housed today, it was given to us in 1956 by the then Chief Minister, Shri Honorable Chand Bhanu Gupta ji. And it has been always been working since then. It is more than nearly 70 years. We have been working there. We have been, now it's lived its life. But it's a huge, huge piece of inspiration because from there our story starts. Sir, you know, you're aware that we undertake teaching of 250 MBBS, nearly a batch of 100 MS students, and we also take teaching of 24 residents, MS residents every year, and we are a big department. We also manage the acute surgical emergencies in the Department of Surgery coming to the King George's Medical University, Lucknow. So if we go by this, it is department is beacon of surgical innovation, compassionate care. First head was Colonel W. Selby. He was an Indian Medical Service officer. Foundation was laid down by the King George's V and is established in 1912. And we work as a close-knit family. You can see the department lecture theater where we have academic programs. We discuss, sometimes we also have teas. And then, sir, before we celebrate our foundation day, we organize 4 or 5 days of master class for PGs. And there, they are taught by the leaders and masters of surgery about the topics which they would be facing in their real life in MS exams. It also has got credit hours, 12 credit hours by NMC, State Medical Faculty. And therefore, it is also useful for those who want to refresh their knowledge and who want to have some state medical faculty credits to them. So it is good for them also. So we started this program before, from 17th or Tuesday of this week. And these are the few pictures where you can see Gitika ji, our organizing secretary, is teaching benign breast disease. Professor Dalila is teaching urology. Residents are there. We had more than 70 registrations from outside of KGMU and more than 70 registrations from India, KGMU. Teachers from PGI Chandigarh also came. So please welcome. Maybe welcome please our ACS, Amit Kumar Ghosh Tarai, sir. So please, yes. He has been doing marathon inauguration since morning, sir. You are doing this in 10 in the morning. And he was caught up in the traffic in Parivartan Chowk, very busy, and still could snatch some of his important time. Thank you, sir, for joining us. It's been real privilege and honor that despite the fact that you were very tired, you could still spare some time for us. And then I was just started reading the departmental reports, sir. So another beauty of this, sir, we were talking about the story of the department foundation day and the education program, and then the importance of this. The other thing is that we also had this skill enhancement workshop in the form of vascular anastomosis, bowel anastomosis, stapling device, and chemoport insertion. So this year also we were given a Power Grid Corporation gave us a SSI Mantra 3.0 robotic system this year under corporate social responsibility. And sir, you would be very happy to know, Chief Guest, sir, and Honorable Guest of Honor, and as for the faculty, that surgery department did first robotic cholecystectomy, robotic procedure, and it was done by me. And we have been able to do more than 35 procedures so far, and it includes a lot of different procedures. And it has been possible because of the support of our leadership, our friends in the former administration, Dr. Ojha, Abhijit ma'am, our Honorable Vice Chancellor, Professor Sonia Nityanand ma'am. So the majority of the, more than 50% of the faculty has taken training and they're on the verge of starting their own surgeries. These are some few glimpses. Now the third aspect was, we talked about education. We talked about teaching MS students. We talked about our TOIS surgical robotic system, which is first in the state of UP, probably, and probably it is also second in the whole country, where we have a robotic system. And I'm happy to know that the government of UP was kind enough to sanction us a new state-of-the-art building in 2024. The construction is underway, and this fulfills the Chief Guest, this fulfills the third aspect of our life, where we want a very good house. And this house is the form of modern temple of places of working, which is this building. This would be a state-of-the-art building where the flow of patients includes modern lecture theaters, skill lab, ICU, HDU, offices, and wards under one roof. And it has been a pet project of Honorable Chief Minister Shri Yogi Adityanath ji, and we also say our thanks to him and the government of UP for giving us this huge grant which we wanted very badly after so many years. This is likely to complete in 2027, and this is a video if I may play it. So coming to this building, I would also like to inform you that this would be the second after AIMS in whole of the country for a department to have a building of this kind. Sir, we employ all modern methods of teaching as envisaged by the National Medical Commission. And this is a breakdown of unit-wise. We have 250 intake of 250 MBBS and 24 MS students. And sir, we have 8 functional units. And every unit does general surgery and area of interest. This is the picture of department faculty. And now coming to the achievements of Department of Surgery faculty, I would not like to speak about myself. The only thing I would say that the first robotic cholecystectomy was done by me in KGMU, or the first robotic procedure. Dr. K.K. Singh, who is sitting on the dais, he was invited to deliver a lecture in SAC conference in Nepal, and he is also a member of the Executive Council because the Dean Paramedical. Dr. Pava has illustrious career. He has been invited to several guest lectures and publications to his credit. Professor Suresh Kumar is a gifted pulmonary and thoracic surgeon, lot of publications, award by Sehat Times and Dainik Jagran, and he also is medical superintendent of one of the biggest hospitals, presumably in Asia or in India. Professor Avnish Kumar he has been invited in several lectures. He has chaired sessions, and he also got this year American College of Surgeons International Guest Scholarship, which provides $10,000, and he has been to several centers of excellence in US. His area of interest is minimal access surgery. Then we have Professor Suren Kumar, who is an excellent gifted endocrine and breast surgeon, and he has been invited as faculty delegate in OncoSurg TMH Mumbai, and he also was invited in Indore, and he also looks after the, he's faculty in charge of human resource. Dr. Geetika Nanda Singh is sitting here. She's an endocrine surgeon, and sir, she's the organizing secretary of this whole program. We also had a program was today's coming to an end, 4-day, 5 days long program, sir. And Dr. Farad Ahmed is a very popular surgeon, and who interacts with the patient in their own language, and he is very revered for this. And he has been to several national and international conferences. Professor Dr. Sanjeev Kumar is a gifted surgeon. His area of interest is anorectal and colorectal surgery, and he undertakes the entire burden of anorectal diseases. Dr. Akshay Anand is co-organizing secretary, and sir, he is a juggernaut. He is a man of many talents, and he is a gifted surgeon, a very dependable ally, and a very good student. He has received appreciation of the Government of India. He has received appreciation of Vice Chancellor. He has received robotic training HPV. He has American College of Surgeons Fellowship, and he received ACS Fellow Observership Program in USA. Dr. Ajay Pal is another hope of the department. He is a deputy medical superintendent, but besides that, he is a very good surgeon, and he received VC Appreciation Award, and he recently also got, which I forget, what was that? Just now you posted in the group, and he is a talented man. And then Dr. Soumya Singh her area of interest is minimal access surgery, and she has received training in robotic surgery and lot of training in Paris, Strasbourg, minimal access surgery diploma in IRCAD. And she also was appreciated in the Research Showcase grant. Dr. Manish Ragwal is also a minimal access surgeon and a lot of publication to his credit. Dr. Kushag Gaurav is true blue Georgian. He did his MBBS MS from here. He did his MCH from GPGI. He's an endocrine surgeon. And he is another dependable ally. And if you give the work to him, it will be kind of done, fire and forget kind of thing. And he has been appreciated thrice by the previous Vice Chancellor because of his excellent work in the King George Medical University, Lucknow. We have 3 young faculty members, Dr. Amit Karnik, Dr. Nizamuddin Ansari, Dr. Vaibhav Raj Gopal, and Dr. Amina. They are workforce of this conference. They have been working very hard. They have supported us through and through in the conference. The positions. Now, sir, coming to the backbone of our department, sir, there is a short story, if I were permitted to tell, that there was a man sitting in the restaurant having his lunch or breakfast, whatever it was, and a man came to him, Mr. Colonel so-and-so. He said, yes, I am Colonel so-and-so. He said, sir, I was the man who packed your parachute. So these people are, sir, residents. They are our parachute, the nursing officers, the class 4 employees, the ministry office. These are the people whom we rely upon, and they work tirelessly day and night. And I would request my hall to give them, appreciate them by clapping, the nursing officers, the residents, those who stay at night and do all our work, and still scolded by us that you did not do it rightly and properly. Sir, Dr. Pankaj, he got first prize in APSICON, Breast Surgeons Conference in Kolkata. Dr. Swapnil, Dr. Akanksha Singh, Dr. Apurv, Dr. Jyoti Singh. Sir, this Dr. Anirudh, he stood first in 7th, he ranked 7th in super specialty course, NEET SS course, so he can choose his branch of his interest. And Dr. Harsh, Dr. Kumar Kaushik. So these all people are here whom you see. Dr. Palaprulu Jyotirmayi, she got gold medal in surgery, recently concluded exam. Dr. Amit Kumar, Dr. Shiva, Dr. Aryan, Dr. Chinmay, Akansha, Koni, Hemant, Mitlesh Kumar, Pankaj Kumar, and Swapnil. And they have all brought laurels to us, sir. So before we end, just a glimpse of the department, sir. More than 67,000 VC patients in OPD, nearly 9,000 in IPD admissions, 5,000 major abdominal surgeries, nearly 4,000 emergency surgeries, and to add to this, we have done 34 robotic different procedures by SSI Mantra robotic system, and we also do endoscopies, sir. So this is a glimpse of the different procedures we do. Sir, we take pride in the fact that we are Department of General Surgery, and still we do different procedures which are done only in specialty, but because of the reason that nearly all the faculty is trained outside of India. And there some are trained in Tata, some are trained in UK, some are trained in US and Italy and other things. Just a glimpse of the different kinds of surgeries. Sir, at the end I would say thanks to University Administration for giving us whatever instrument we want. And at the same time, sir, you are representing government. We are also thankful to you that you were kind enough to come. And your predecessors gave us buildings, sir. And andha kya maange tu aake kind of thing. We need it desperately, we need it badly. And when it will be there in 2027, it will be one of its kind in whole of the India. After AIIMS Delhi, it will be another building in whole of the country. And that too having robotic systems, sir, we are doing robotic surgeries, we are democratizing the robotic surgeries. And sir, this is a moment of gratitude also to you, to our seniors sitting on the dais, and a moment of gratitude for our residents, our nursing staffs, and the ministerial staff, and all these people who help us do our chores regularly and daily, and without whom we wouldn't be able to move a single step. Thank you very much, sir. Thank you.
Thank you for the comprehensive report, sir. Due to paucity of time, our chief guest, Dr. Anil Goyal, sir, has to leave early. So I now invite sir to enlighten us with a few words. Sir is an alumnus of KGMU 1975 batch, a renowned urologist and honorable member of Legislative Assembly representing Krishnanagar constituency. Sir has been a steadfast advocate for strengthening healthcare infrastructure. It is a privilege to have you here, sir.
Thank you. Good afternoon. And at the outset, I would like to thank Dr. Sonkar for inviting me here. And it is not as a chief guest. I feel I am an alumnus who is standing here. I feel privileged. I feel proud under the leadership of your surgery department is doing wonders. I compliment you not only for the surgery department, but for the 5 days conference which you just did. And I just saw your work being done, whether it is robotic surgery, advanced laparoscopic surgery, or the routine emergency operations. They are in thousands. They are in thousands. I think you are none less than All India Institute of Medical Sciences, Delhi. That is what I can say. Not as an alumnus, because on the dais, there are distinguished dignitaries, Amit Kumar Ghoshji, Additional Chief Secretary, Medical Health, Family Welfare. I'm sure under the able leadership of our Chief Minister, Yogi Ji, this institution is going to have the wonderful new block that is 2026 Surgery Department in very near future. I have Professor Abjit Kaur, Pro Vice Chancellor, HOD Ophthalmology, and I still remember her when she joined in 1980. I was here in Delhi, KGMC, that was King George's Medical College. Now it is KGMU. I was here in 1975 to 1985. And I distinctly remember Dr. Chhavdan today here, that he was our teacher, he was a lecturer, and he taught us not only the surgery, but also how to deal with the difficult situation in your life. I remember him today on this dais. Dean Academics, Dr. V.K. Attram, HOD Medicine also, CMS, Dr. B.K. Oja, Dr. Sonkar, Professor K.K. Singh, who is Professor of General Surgery, and Dean Paramedical Sciences. Dr. K.M. Singh was one person because of whom I am a urologist, and Dr. K.K. Singh happens to be his son. I compliment you. I remember Dr. K.M. Singh also today. Organizing Secretary, Dr. Geetika Nanda Singh, and distinguished members of the Urology Society also. Dr. Apul is a dear friend, Dr. Dalela, Pava, and then many more young students, residents, and also many teachers are also. सिर्फ साइट ऑफ डिजीज़ जान लो, बस इतना काफ़ी है. उसके बाद आगे आप बढ़ते जाइए, उस फाउंडेशन पर आगे बढ़ाते जाओ. आज इस फाउंडेशन डे में मैं उनको याद करता हूँ. मैं याद करता हूँ डॉक्टर A.K. वाकलू साहब को. इस फाउंडेशन डे पे जो सर्जरी की, एक दिन के बच्चे में 1980s में वो प्राइमरी ARM करते थे. एक दिन के बच्चे में 1 स्टेज प्राइमरी ARM करते थे. डॉक्टर वाकलू हुए चाहे डॉक्टर टंडन हुए, इस प्रकार के लोगों से हमने अपना फाउंडेशन सीखा. और आज आप सब लोग जितने रेजिडेंट यहाँ बैठे हैं, वो डॉक्टर सोनकर की टीम से भी वही सब सीख रहे हैं, बिकॉज वही सब लिगेसी है जो हम लोग आगे बढ़ा रहे हैं. वो लिगेसी है जो डॉक्टर अपुल गोयल बढ़ा रहे हैं, या पावा बढ़ा रहे हैं, दलेला साहब बढ़ा रहे हैं. वो लिगेसी है, उसको आपको इम्बाइब कर रहे हैं, उसको एक इम्बाइब करने की जगह है ये. ये सिर्फ सर्जरी सीखने की जगह नहीं है, ये सीखना है जीवन में आगे कैसे बढ़ना, उसका फाउंडेशन. इस फाउंडेशन डे पे I also feel that it is honor that I am standing here as alumnus, but the emotion is deeper. The place is just not an institution for me, it's a foundation, turning point, and a lifelong experience. Years ago, this hall, where this hall is now, this was a playing ground. अब जी आप याद है आपको, सरदार पटेल के हॉस्टल से पीछे मेरा कमरा था, उससे ये दिखाई देता था. फिर ये अटल बिहारी वाजपेयी ऑडिटोरियम और ये सब बना, हमारे सामने बना. तो वो नर्वस में था, कुछ वार्ड में जाते थे नर्वस होते थे, लेकिन ओटी पोस्टिंग्स में एक्साइटेड भी होते थे हम लोग. और but then humbled by the responsibility that surgery places on our shoulders. What I received here was not just surgical training, but as I said earlier, the discipline, the ethics, the courage, and the respect for human life. And this is where this surgery department role lies. A department of surgery is unique. It teaches us decisiveness under pressure, precision with compassion, and leadership in most critical moments. Every incision teaches humility. Every complication teaches us responsibility. And every successful recovery reminds us why we chose this noble profession. I would like to pay again my heartfelt respect to our teachers, past as well as the present leadership, sitting on the dais, sitting off the dais. A surgeon, as I said, Professor P.C. Dubey को उन्होंने क्या कहा मुझे आज भी याद है. उन आर.पी. साई साहब ने क्या कहा ये उनके पेशेंट्स को भी याद होगा, आपके पेशेंट्स को भी याद होगा कि we never forget the teacher's words spoken in OT or at the bedside. The habits we follow today, the ethics we uphold, and the confidence we carry, all are the reflections of our mentor. I salute them. Once again, I salute all my teachers, which I have named or I have not named. To the residents and young surgeons here today, surgery will test your patience, it will demand sacrifice, it will challenge your ego, but it will reward you with immense professional satisfaction. Never let stress replace empathy, never let speed replace safety, and never let success distance you from your humility. Remember, patient may forget your degrees, but they never forget your behavior. That's very, very important, that you have to be available. I would say A, B, C, D. You have to be available, you have to have a good behavior, you have to have a competence, and you have to have decisiveness in your life to be a successful surgeon. And what decisions? Decision is that you do no harm, where you may not be able to do good, but you do no harm. That's the basic of any surgery, or for that matter, medical science. When we talk of modern era, minimally invasive surgery, robotics, AI-assisted diagnostics, and evidence-based protocols, technology will evolve, but the surgeon's responsibility remains timeless: to heal when possible, to help always, and to harm never. Again, I would say my roots are here. I may be in any part of country. I did my MBBS, MSc or MCH from Jaipur Medical College, worked in all institute surgery, and started my own. But the roots lies here in this department, these corridors, these wards, and these operation theaters. Returning today feels like coming home. I had a golden jubilee in December, and I went to meet Dr. Sonkar and saw the department. I was so overwhelmed with his work, the expertise of the consultants and the residents, with the availability of Myntra SSI, the robotic procedure. I congratulate the department once again, Dr. Sonkar, your team, your students, which I just saw their achievements for their academic excellence, clinical standards, and commitment to patient care. Because you are treating not only hundreds, but the thousands of patients every year, surgery, OPD, and also, as you said, more than 10 specialty or subspecialty operations are being done in Department of Surgery. I am confident that this institution will continue to produce surgeons like Dr. Gupta, who stood NEET SS 8th rank, and there are many more like them, will continue to produce surgeons who are not only technically skilled, but ethically strong and socially responsible. Once, I thank you for giving me this opportunity. I wish the department, faculty, and students a future full of skill, success, and above all, service to humanity. Jai Hind.
Thank you for your inspiring words, sir. I now request our Honorable Pro Vice Chancellor, Professor Abhijit Kaur Ma'am, to kindly felicitate our Chief Guest, Dr. Anil Goyal, sir. Thank you, everyone. I now request Professor B.K. Ojha, sir, our Chief Medical Superintendent, to share his thoughts. The head of the Department of Neurosurgery, sir, is a highly accomplished neurosurgeon and academician, known for his expertise in complex neurosurgical care and his commitment to institutional excellence.
Very good afternoon, everyone. Congratulations to whole team of general surgery on this 114th Foundation Day. As a CMS, I have to say that I don't get any complaints from general surgery department. So definitely, department is being run by good hands, and they are having good relationship within the department. That is why no complaints are coming. From a neurosurgeon point of view, I will say on Foundation Day something from ChatGPT. Year after year, they are doing better and better. I salute them with gratitude and cheer. And जनरल सर्जरी की मजबूत नींव पर न्यूरो सर्जरी का हुआ विकास, आपकी वजह से हमारा अस्तित्व, धन्यवाद आपको और आपका बहुत ही सम्मान. Thank you.
Thank you, sir. I now invite Professor Virendra Atam, sir, Dean Academics and Head of the Department of Medicine, to address the gathering. A distinguished professor of medicine with over 4 decades of experience, sir has been a pillar of academic strength and mentorship. We welcome you, sir.
Good afternoon. So dignitaries on dais and off dais, my senior teachers, my colleagues, eminent orators who are coming from our neighboring countries, students and residents. On this Foundation Day of Surgery, I congratulate Head of Department. Foundation Day is not just a day, it's just a showcase of a department. Department of Surgeries has given excellent teachers, excellent surgeons, and excellent researchers. So this legacy is carried forward very wonderfully by the Head of Department, Dr. Sonkar. I congratulate for him for this. Not only this, they have kept the pace with the modernization of the surgeries. They are not doing the robotic surgeries, for which I congratulate the full team, faculty, residents of Department of Surgery. I also honored that we have here with us with the eminent orators, which are coming from Bhutan and Sri Lanka and from India. And by their vision, it's going to be a very good feast to our residents, and they will learn, they will have a knowledge with not only the residents, also with also the consultants. So once again, I congratulate everyone, and I congratulate Head of Department for this oration. Thank you very much. Best wishes. Jai Hind.
Thank you, sir, for your kind words. We now arrive at a significant and celebratory segment of today's program, the award distribution ceremony. A moment dedicated to recognizing excellence, acknowledging contributions, and expressing our sincere gratitude to those who have enriched this academic event. I respectfully invite our honorable dignitaries to kindly step forward for the presentation of mementos. We begin by felicitating our esteemed orators whose knowledge, dedication, and invaluable guidance have made this program a remarkable learning experience. May I request Dr. Sonam Dukpa sir, who delivered Professor P.C. Dubey oration, to please come forward for the memento. We sincerely appreciate his enlightening talk and valuable experience.
So, Dr. Sonam Dupka, he is a pioneer first general surgeon of Bhutan, 1982 to 1992. And he was president surgeon, the prime minister surgeon. And in his words, he was the only surgeon for some time to the whole of Bhutan. He is presently serving as a consultant surgeon in Mengjong Diagnostic University, Thimphu.
Now may I request Dr. Bhavan Gamage sir, who delivered Professor T.C. Goel guest lecture, to please come forward for the memento.
Dr. Bhavanta Gamage, Professor in Surgery, Faculty of Medical Sciences, University of Shri Jayawardene, Consultant Surgeon, Colombo South Teaching Hospital, Sri Lanka. He is also President-elect, College of Surgeons, Sri Lanka.
Thank you, sir. Now the department would like to award the residents for their excellence in research and clinical work. Third position is shared by Dr. Jyotirmay and Dr. Pankaj. Dr. Pankaj. Second position goes to Dr. Rajat. And the first position goes to Dr. Shiva. Hearty congratulations to all the award recipients. Your dedication and excellence are truly commendable. अब हम अपने विभाग के नर्सिंग ऑफिसर्स, ओटी टेक्नीशियंस और समस्त कर्मचारियों को सम्मानित करना चाहते हैं जो अपनी पूरी निष्ठा और निपुणता के साथ हमारे विभाग में कार्यरत हैं। शुरुआत करते हैं नर्सिंग ऑफिसर्स से। श्रीमती विजी नायर, डीएनएस इमरजेंसी सर्जरी ओटी। श्री केनी फिलिप, असिस्टेंट नर्सिंग सुपरिटेंडेंट आरएसओ। Shri Kenny Philip, Assistant Nursing Superintendent, RSO. Srimati Mamta Yadav, Nursing Officer, Post-Operative Ward. Srimati Parul Yadav, Nursing Officer, Surgical Ward 1. Srimati Kiran Chaurasia, Nursing Officer, Surgical Ward 2. Srimati Vijay Bharti, Nursing Officer, Surgical Ward 3. Shri Pradeep Kumar, Nursing Officer, Surgical Ward 7. Srimati Preeti Yadav, Nursing Officer, OT1. Srimati Savita Yadav, Nursing Officer, OT2. Srimati Seema Pandey, Nursing Staff, OT3. Srimati Meenu Srivastav, Staff Nurse, RSO. Srimati Rani Pandey, Staff Nurse, OPD. OT Technician Shri Roshan Pandey, Laparoscopy Lab. Shri Mayank Tiwari, OT1. कार्यालय से श्रीमती ज्योत्सना श्रीवास्तव, जूनियर एडमिनिस्ट्रेटिव ऑफिसर। लिपिक संवर्ग से श्री धर्मेंद्र पांडे। हॉस्पिटल अटेंडेंट श्री सुमित, पोस्ट ऑपरेटिव वार्ड। श्री धर्मेंद्र, सर्जिकल वार्ड 1। श्रीमती बचाना, सर्जिकल वार्ड 2। Shri Harish, Surgical Ward 3. Shri Kuldeep, OT 5. Safai Karamchari Shri Arvind, Surgical Ward 2. Srimati Deepmala, OPD. Srimati Deepmala. Shri Virendra, OT 3. सभी अवार्ड विनर्स को एक बार फिर से हार्दिक बधाई. Now I request everyone to kindly come forward for the group photograph. Thank you, everyone. I now welcome our guest of honor, Mr. Amit Kumar Ghosh, sir, Additional Chief Secretary, Medical Health, Family Welfare and Medical Education, Government of UP. Sir's distinguished administrative career and visionary leadership have played a pivotal role in strengthening public health systems, medical education, and healthcare delivery across the state. It is a privilege to have you amongst us, sir.
Dr. Abjit Kaur ji, Pro Vice Chancellor, Dr. Sonkar, the Head of Department of Surgery, and our Chief Host here, Dr. KK Singh ji, Professor Dr. Virendra Atam ji, Dean Academics, and he's a medicine man, Dr. B.K. Ojha, the Chief Medical Superintendent, and a neurosurgeon, Dr. Geetika Nandaji, the organizing secretary. Present here in the hall with me, my colleague, Srimati Archana Gaherwarji, Registrar of KGMU. Here also present, I think he was present, where is Avinash? So, friends, distinguished orators from Bhutan and Sri Lanka and other places. Actually, I must express at the outset my deep gratitude to Professor Dr. Sonkar for having me over here. And it is always a delight and an honor to come back to this hall and be with you all. Once you come here, you become more and more aware that you are sitting at a place which has witnessed much history. and has made much history in the medical world. To be amongst the top 10 in the NIRF ranking as of now is but a minute reflection of the achievements of KGMU over more than 100 years. The Department of Surgery is a large department here with 215 students passing out of this department, graduating per year. And as one can see, from the first surgeon of Bhutan to distinguished MLA from Delhi. So the footprint of this department, the footprints of this department rather, are to be found across nations and in different milieu. No doubt, the place our alma mater, our department shapes to a great extent. You know, it is like when you are launched as a young person, for many, many years, the very energy imparted to you by the department and your faculty carries you through. Then later, a time comes, you recalibrate, you regroup, you re-energize, you, so to say, refuel, and then continue your journey. So, while you, oh, he has come back. So, what I was saying was that all of us who have passed out of institutes of excellence, we know that we carry on our shoulders a great legacy also. We are never really alone. In our journey, वो कहते हैं कि हरिश्चंद्र, क्या नाम था, बच्चन जी ने जो कहा है, अमिताभ बच्चन के फादर ने, कि हरिवंश राय बच्चन, बताइए मैं नाम भूलने लगा हूँ, तो वो कहते हैं कि पर गए कुछ लोग छोड़ अपने पैरों की निशानी, ये निशानी मूक होकर भी बहुत कुछ बोलती है, खोल इनका अर्थ पंथी पंथ का अनुमान कर ले, पूर्व चलने के बटोही बाट की पहचान कर ले. तो what he is saying is that wherever we are, there are, you know, in the sands of time, footprints of the giants who have also gone there ahead of us. And they have discovered the world of science and the world of knowledge. तो जिस वर्ल्ड में हम आज रह रहे हैं, this world is a legacy, a precious legacy, जिसे हमें आगे बढ़ाना है. We have to carry on with their message. So it is always a delight to come to the foundation day of any such distinguished department in a place like KGMU. And on this occasion, I extend my best wishes to the Vice Chancellor, to the Pro-Vice Chancellor, to the HOD, his entire team, all his collaborative departments, the 5 departments allied to the Department of Surgery. I also wish all the best to the champions, top researchers, gold medalists, students, and I hope that wherever you will go, today Honorable Prime Minister has tweeted a shloka from the Gita, Bhagavad Gita, and what he has said, I looked up the meaning from Bhagavad Gita. It says that once I reveal the true knowledge, which is the true science to you, indeed you shall have no doubts, but you will have clarity as you go ahead. Of course, Lord Krishna is speaking in the context of the situation, but this is also, as somebody has said, the song celestial, and the message of Bhagavad Gita is as relevant to all of us in our lives wherever we are. So, to know the true knowledge is to be scientifically minded, always question and then decide on the basis of evidence. I wish you such scientific temper in the years ahead, and I extend my best wishes to the Department of Surgery, and I thank them from the bottom of my heart for having me over here. Thank you so much.
Thank you for your inspiring words, sir. I now request our Honorable Pro Vice Chancellor, Professor Abhijit Kaur ma'am, to kindly felicitate our chief guest, our guest of honor. Thank you, sir. Thank you, ma'am. I now invite Professor Abhijit Kaur ma'am, Honorable Pro Vice Chancellor and Professor and Head of the Department of Ophthalmology, to grace the podium and bestow upon us her words of wisdom. We welcome you, ma'am.
Good afternoon, dignitaries on the dais and off the dais. The Department of General Surgery has a very special place in my heart for many, many reasons. One, that my favorite teacher was the head of Department of General Surgery when I joined, Professor P.C. Dubey. And I admired him not for one reason, that he was a good surgeon. I admired him for his bedside manners, for his immaculate dress-up, and his sense of timing. And this was common between, I think, all the surgeons of that time. They all wore white. They had light-colored trousers, a white shirt, and an apron, which has now become a rarity in the Department of General Surgery, I think. I don't see many surgeons wearing an apron now. As far as teaching was concerned, Professor P.C. Dubey, I think his knowledge of anatomy was so good that he used to vouch for a bloodless incision. And in teaching the undergraduates, this famous Jigyasa diary of Professor T.C. Goyal, whoever wrote 3 questions per session and had the maximum questions in his Jigyasa diary used to get 5 marks extra. What a beautiful way of innovation in teaching. What we say, that a teacher does not have to give a didactic lecture. He has to strike that spark in you that you can start thinking for yourself. और सर की क्लास में आने से पहले हमेशा ये लगता था कि कुछ तो सवाल पूछ लें. Because at that age and stage in life, most of us just, for us it was used to go to the ward, learn by rote. Signs, symptoms याद कर लो, treatment याद कर लो. सोचते तो थे ही नहीं. But that, igniting that instinct to think is a very, very important part of us as teachers, a role that we should play. As a colleague in this college, I think there is no member of the Department of General Surgery who is not available at a phone call. कभी भी नहीं होता. किसी को भी आप कॉल करो, जो भी इमरजेंसी में है. Not that I'm on a position today, even as a young faculty member. So their commitment to patient care has been equally well nurtured in the department, and I'm sure they are handing down these values. With regard to supporting the university, I don't need to name. I think there is hardly a faculty member of this department who is not playing a pivotal role in one field or the other. My heartiest congratulations to all of you for not only taking up your subject, taking it forward, getting accolades, but also simultaneously of giving of your personal time and effort. This is an extremely important part of a duty as a faculty member. For the residents, you'll work, I think there is no word, you'll work like horses. If there was a horsepower calculation for residents, I think the residents of general surgery would top the list. Congratulations to all of you, to the staff, to the nurses, to the paramedical staff, to the supporting staff of the department. Each one of you deserves a real applause. Can I ask the hall to kindly give the Department of Surgery a big applause? Thank you, and heartiest congratulations once again. God bless.
Thank you, ma'am, for being the backbone of our department and for lending us your shoulder to cry on when we have something to say. I now request the senior faculty of the surgery department to come on the dais, Professor Pawar sir and Suresh sir, KK Singh sir, to felicitate the dignitary on the dais, the Pro Vice Chancellor, the CMS and the Dean. First, the Pro Vice Chancellor. Ma'am, Professor Pawar sir and Professor Suresh sir. As we felicitate our dignitaries, the real backbone of our administration, a couple of couplets. वो आए घर हम में हमारे खुदा की कुदरत है, कभी हम उनको कभी अपने घर को देखते हैं. Next, I'll request the dignitaries to felicitate our Dean sir, Dr. Virendra Atam sir, who is also the HOD of Medicine. Next, we felicitate. Next, we felicitate our CMS sir, Dr. B.K. Ojha sir, who is also head of department neurosurgery. Sir is also chairman of robotics core committee, and under the dynamic chairmanship of sir, we are honored. We have started a successful robotic program so far. We have done over 50 surgeries, and we have got 3 robotic systems fully running.
Thank you, everyone. We now come to the end of this ceremonious event. I invite Dr. Gitika Nanda ma'am, Organizing Secretary, to kindly deliver the vote of thanks.
Good afternoon, everyone. Over the past 5 days, we have been sharing knowledge, exchanged ideas, and developed multiple connections. But the success of any conference could never be alone. It could never be one person's effort. So it is the collective contribution of many dedicated individuals who came together to make this conference what it happened. First and foremost, I would like to thank the Almighty for His help and blessings. My heartfelt gratitude to our chief guest and the guest of honor, Mr. Amit Kumar Ghosh and Dr. Anil Goyal, for gracing the occasion with their presence despite their busy schedules. I also extend my thanks to Professor Abhijit Kaur Ma'am, our Pro Vice Chancellor, Professor Virendra Atam Sir, Dean Academics, and Professor B.K. Ojha Sir, Chief Medical Superintendent, for their presence and bestow their blessings on us. My sincere thanks to all the chairpersons and to the orators, and also to the speakers who enlightened us with their words for all the 4 days. Your contribution has been instrumental to the success of this program. My special thanks to Professor Abhinav Arun Sonkar Sir for giving me the responsibility to take the charge of this program, and Dr. Akshay Anand, who worked with me every minute for this program. I also thank my colleagues, especially Dr. Amina Khan, Dr. Faraz Ahmed, Dr. Amit Karnik, Dr. Vaibhav, and Dr. Nizam for their help and dedication towards this program. My sincere thanks to Soumya and Raj for always standing with me and bearing me. Without you, I could not do what I did. Also, thanks to my residents. Special mention Dr. Ashna, Dr. Apurv, Dr. Neetu, Dr. Priyansh, Dr. Pankaj, Dr. Rajat, Dr. Swapnil, and Dr. Harsh for working tirelessly with me with utmost sincerity. I also thank our paramedical students, Manjali, Divya, Shraddha, and Anshika, for their contribution towards this program. A special mention to our technical team, Mayank and Roshan, for their help throughout the workshops, and Mr. Bindu and the staff and workers of surgery for their efforts towards smoothly carrying out this program. I also thank the Royal Ayojanam team for treating us with all the delicacies for all these 4 days with the utmost service. Thanks to our media and to the residents of other colleges as well. Without you, this program could not have had any role. I may have missed some names during this course, but I thank you each and everyone who worked in small or big way towards as a contribution towards this program. So thank you all once again, and your participation and your presence meant a lot to us. Thank you.
Thank you, ma'am. I request everyone to kindly rise for the national anthem before we disperse for lunch. With gratitude in our hearts and renewed commitment in our minds, we conclude the inaugural ceremony of the 114th Foundation Day of the Department of General Surgery, KGMU. I cordially invite everyone to join us for lunch that has been arranged downstairs at the Convention Center parking area. I request all the dignitaries to kindly stay back for a group photograph. I invite all the faculty and the residents of the Department of General Surgery to kindly join in for a group photograph.